dear friends, for today's CME, Art and Science of Vaginal Surgeries. This decade has seen a resurgence of hysterectomy by vaginal route for indications other than uterine prolapse. Emphasis on minimal invasive surgeries today has led to revival of interest and importance of NDVH. Also, this route gives a safer operative corridor to surgeons. So today we have gathered here to know more about the intricacies and the challenges in NDVH from the stalwarts in this field. So on this note, we begin with our first session. I call upon the chairperson for this session, Dr. Zamre Madam and Dr. Sujata Kulkarni, to please take their seats.
Dr. Sulbha Zamre Madam, she is a senior consultant OBGYN since 35 years at Zamre Nursing Home, worked as honorary consultant in Railway Hospital, VM Medical College, etc. Worked in various capacities in arranging various conferences in Solapur. Her areas of interest are ultrasonography and high-risk obstetrics. Dr. Sujata Kulkarni. Dr. Sujata is working as a consultant OBGYN in Banashankari Devi Hospital since 20 years and Ramakrishna Hospital. Areas of interest are infertility and adolescent gynecology. Given lectures on adolescent health in schools and colleges. Now over to you, chairpersons.
Thank you so much for those kind words, Meena. A very good morning, one and all. We are starting with this first session on today's CME on Art and Science of Vaginal Surgeries. It is very rightly said that our eye sees what our mind knows, and that is so true for ultrasonography. Ultrasound has been our right hand since a decade now, and we are very fortunate to have with us our radiologist colleague, Dr. Vaibhav Meru. Dr. Vaibhav Meru has done his DMRD from Jawaharlal Nehru Medical College, Belgaum. He is director and consultant radiologist at Prism Medical Diagnostic Center and SP Institute of Neuroscience. He is going to talk on role of ultrasound screening before NDVH. Over to you, sir, Dr. Vaibhav Meru.
Good morning, everyone. At the outset, I would like to thank Dr. Virkar sir and Dr. Manik Guram sir and office bearers of the SOGS for inviting me to give me this talk. In next 30 minutes, I will try to give my best justice to this talk, which is given to me. The talk is pre-operative imaging assessment in non-descent vaginal hysterectomy. Surgical removal of non-prolapse uterus of size 12 weeks through vaginal route is non-descent vaginal hysterectomy. History, Langenbeck first performed vaginal hysterectomy in 1813. Non-descent vaginal hysterectomy pioneered by him in 1934. Why vaginal route is the safest, most cost-effective, less complication, fast recovery, less hospital stay, and obviously without any visible scar. Indications: dysfunctional uterine bleeding, fibroid uterus, adenomyosis, chronic pelvic pain, postmenopausal bleeding, pyometra, cervical dysplasia, cervical polyp. Contraindications: uterus more than 12 week size, adnexal pathology, limited vaginal space, restricted uterine mobility, adhesions, cervix flushed with wall, previous history of fistulae, repair. This is preoperative evaluation, clinical, should be done under anesthesia, evaluation of pelvic support for uterine mobility, evaluation of pelvis, angle of the pubic arch, 90 degrees or greater, descent of cervix, mobility of vaginal mucosa, vaginal canal should be ample, posterior vaginal fornix should be wide and deep. Now, the role of ultrasound to confirm the diagnosis and the planning of surgery, size, dimensions of uterus in all planes, volume of the uterus, mapping of fibroids, transverse diameter of the fundus more than 10 centimeter, cervico-uterine border, endometrial thickness, endometrial myometrial junction, adnexe, fluid in pouch of Douglas, PID, ascites especially in ovarian tumors, post-void residue especially in case of urinary tract infections or obstructive uropathies, KUB, especially if the fibroid is larger, it's compressing the ureters, its effect on the kidneys pre and post-op, genitourinary anomalies, lymphadenopathy in case of malignancy, color Doppler flow studies in case of malignancy. How to assess, UHG assess the volume of the uterus. The volume is calculated by length into breadth into AP diameter into 0.542. In 8 weeks, if it's less than 100 centimeter per cube, you can remove the uterus with great ease. If it's less than 200 centimeter, no debulking is required. For 9 to 12 weeks, less than 300 centimeter cube feasible through the vaginal route. 13 weeks onwards, more than 300 centimeter cube needs experience and extra effort to perform bisection and debulking. More than 24 weeks, more than 750 centimeter per cube, better to remove abdominally. This is how you calculate the volume of the uterus by taking 3 diameters into 0.542. Uterocervical border. If the uterocervical border is acute, less than 90 degrees, it is difficult for the ligation of the uterine arteries. And if it's 90 degrees or more or obtuse angle, the ligation will be easier. Cervical length. Elongated cervix sometimes may pose challenge at the time of the vaginal or abdominal hysterectomy in seeking to enter the cul-de-sac from below or vagina from above. Documenting normal cervical length is always important. This is the clinical scoring which they have given. Lesser the number of score will be better for the vaginal hysterectomy. Size of uterus less than 8 weeks, 8 to 10 weeks, more than 10 weeks. Mobility of uterus good, fair, poor. Intertuberous distance more than 4 knuckles or less than 4 knuckles. Subpubic angle more than 90 degrees, 90 degrees less than 90. Digital examination of vagina, 3 finger loose, 3 finger tight, 2 finger tight. Mobility of vagina, good, fair, bad. Fornical depth, more than 1 finger crease, 1 finger crease, less than 1 finger crease. Descent with valsalum in concern with ischial tuberosities, more than 1 degree or less than 1 degree. Surgical experience, more than 10 years, 5 to 10 years, 5 years. Previous history, nil, 1 and more than 1. See, the role of the CT and MRI, in case of adhesions, adnexal pathologies, suspicion of malignancy and enlarged lymph nodes, fibroid mapping, urinary pathologies and genitourinary anomalies. Role of hysterectomy in the adnexal masses. If the masses are benign, they're freely mobile, close to POD, the clinical judgment, favorable imaging findings and tumor markers, counseling, frozen section in need, examination under anesthesia, reverse Trendelenburg position to assist gravitational pull. Normal anatomy, this is how it looks on sagittal MRI. This is fundic portion of the stomach, fundus of the uterus, endometrial canal, endometrial myometrial junction, myometrium, cervix, nabothensis. This is the anterior wall, anterior fornix, posterior fornix, bladder. This is vesico-uterine pouch, the posteriorly rectouterine pouch. This is how it looks on transverse section. This is the transverse section of the vagina, that is the urethra, and this is the anal sphincter complex. Everyone is familiar with this anatomy on the ultrasound. This is fundus, this is triple line endometrium, cervix, vagina, bladder, and the rectum. And how it looks on TVS, this is again triple line endometrium, myometrium, fundus, cervix. Fibroids. Fibroids clinically presents as abnormal bleeding, vaginal bleeding, pain, infertility, and palpable masses. Location, intrauterine, submucosal, intramural, and subserosal. Extrauterine, broad ligament, cervical, as well as parasitic fibroids. Mapping of the fibroid is to know number of fibroids, size of the fibroids, location of the fibroid, type of the fibroid, whether they are calcified, whether they are necrosed. If the size is more than 10 centimeters, it may be difficult to remove it through the vaginal route. The relation of the fibroids to the endometrial cavity. 3D TVS ultrasound is the best way for the mapping. This is the figure classification to classify the fibroids. Type 0 is a pedunculated intracavitary fibroid. Type 1 is submucosal, less than 50% intramural. Type 2 is submucosal, more than 50% intramural. Type 3 is intramural in contact with the endometrium. Type 4, 100% intramural. Type 5 in contact with subserosal, and it's more than 50% intramural. Type 6 is subserosal, less than 50% intramural, and type 7 is subserosal pedunculated. And in which there is one more entity called hybrid leiomyomas, which are in contact with both endometrium as well as subserosa. Type 2 to 5 comes under these hybrid leiomyomas. This is the normal image, 3D image of the uterus, endometrial cavity, fundus, and cervix. This is how fibroid looks on ultrasound. There is a comparison between the fibroid as well as endometrial polyp. This is type 2 fibroid encroaching the endometrial cavity, and the endometrial polyp is echogenic within the endometrial cavity, and on Doppler you see the parent vessel. This is intracavitary fibroid. This is how it looks on 3D images. These are the couple of fibroids, both in lateral walls of the both along the lateral walls of the uterus. The one on the right side is encroaching the endometrial cavity, and this is the beautiful depiction how it looks on the coronal reformations. This one may be difficult to remove vaginally. It is on the left lateral wall encroaching towards the cornu, also encroaching this canal. This is again intracavitary fibroid enclosed with junction and encroaching the cavity. This is fundal fibroid, again encroaching endometrial cavity. This fibroid is located posteriorly and it is subserosal. This is coronal reformations in which you can see that there is a type fibroid and its encroachment into the endometrial cavity. Again, reformation sagittal in which there is a fibroid which you can see beautifully encroaching the endometrial cavity. Subserosal fibroid, how it looks on MRI, and there are multiple black small intramural fibroids located within the myometrium. This is again a large subserosal fibroid on the posterior wall of the uterus. This is broad ligament fibroid. The mass lesion is in the left adnexa in close proximity with the uterus and extending superiorly into the abdominal cavity. Pedunculated fibroid arising from the fundus of the uterus, extending superiorly into the abdominal cavity and also compressing bladder. Endometriosis is a common chronic gynecological condition defined as presence of functional endometrial glands and stroma-like lesions outside the uterus. It manifests in three ways: superficial, that is peritoneal disease, ovarian disease, and deep endometriosis. It's highly associated with adenomyosis, in which endometrial tissue is confined to the uterine musculature. Size varies, ranging from microscopic endometriotic implants to large cysts and nodules. Deep infiltrating endometriosis is complex and surgically challenging. Mode of the spread through the retrograde menstruation through the fallopian tube into the ovaries, and also it disseminates vascular through vessels. Rectouterine disease, one which is in the rectouterine pouch, then into vagina, and this is into the rectum. Distribution, you can see along the wall in the ovary, vesico-uterine pouch, rectouterine pouch, and along the rectum. This is beautiful picture of the endometriotic cyst, well-defined cystic lesion with uniform internal echoes. This is a case of deep infiltrating rectovaginal endometriosis in which you can see this lesion which is infiltrating the posterior fornix of the vagina, vaginal wall, and also into the rectum. Scar endometriosis, hypoechoic lesion with irregular margins noted along the subcutaneous fat plane of anterior abdominal wall, showing certain few vascularity. This is a classical of scar endometriosis. Adenomyosis or uterine adenomyomas is a common uterine condition of ectopic endometrial tissue in the myometrium, sometimes considered a spectrum of endometriosis. Although most commonly asymptomatic, it may present with menorrhagia and dysmenorrhea. Commonly seen as the uterus is bulky with asymmetric thickening along the anterior wall with ill-defined echogenicities along the myometrium. Endometrial myometrial junction is seen clearly here. Here you can see the linear hypoechoic striations noted along the endometrial myometrial junction extending into the myometrium, classical appearance of adenomyosis. This is again echogenic lesion in the right lateral wall with thinning of the endometrial myometrial junction here. On the left side, this junction is seen clearly. Diffuse adenomyosis, the uterus is bulky. The myometrium is replaced by hypointense lesions. The global outline is there. There is asymmetric thickening of the wall, more so anteriorly. It is pushing the bladder. This is it is interspersed with few hyperintense foci everywhere. This is a classical appearance of diffuse adenomyosis on MR. Endometrial carcinoma, generally considered the most common gynecological malignancy. It frequently presents with vaginal bleeding. Both ultrasound and pelvic MR are useful for evaluation. Endometrial carcinoma usually appears as thickening of the endometrium, though may appear as a polypoid mass. Premenopausal normal endometrial thickness varies through the menstrual cycle. Diagnosing abnormally thickened endometrium depends on knowing the patient's point in the menstrual cycle. Postmenopausal, more than 5 mm is thickened, more than 8 mm on hormone replacement therapy or tamoxifen. This is the classical appearance, diffuse thickening of the endometrium with irregular margins, showing vascularity extending into the myometrium as well. Just to cover ovarian malignancy, these are the bilateral adnexal masses enhancing and along with presence of the ascites. Adhesions. Peritoneal adhesions are a distinct entity characterized by formation of the bands of fibrous tissue that join intra-abdominal organ to each other or parietal peritoneal surfaces on either side. Adhesion forms as a result of body's healing process after an episode of traumatic, ischemic, infective or irritative insult in a manner similar to scar formation. The term adhesion is applied when the scar tissue extends from the surface of organ to another organ, usually across body cavities such as peritoneal. Peritoneal adhesions had a significant impact over the quality of life of millions of people worldwide due to related small bowel obstruction, difficult surgical exploration, chronic abdominal pelvic pain, and even female infertility. Postoperative adhesions are an important concern for gynec surgeons, oncologists, and infertility specialists. Several gynec and obstetric events have been a major source for peritoneal adhesions. Myomectomy is associated with high degree of adnexal adhesions, mainly when the incision is performed on posterior uterine wall. Surgical treatment of gynec malignancy may be associated with intestinal obstruction either by persistent growth, tumor growth, or post-op adhesions. Peritoneal adhesions accounts for 15 to 20% of cases of infertility, and the pregnancy rates are reported to increase from 38 to 52% with adhesive lysis. Ectopic pregnancy have also been implicated as possible sequelae to the peritoneal adhesions. The association between the adhesions and the chronic pelvic pain is well established in studies which have shown significant regression of pain following adhesiolysis. Presence of peritoneal adhesion is an important concern in a patient who needs an abdominal surgery, precise preoperative planning in terms of operative approach, surgical technique, and the need for an attending gastrointestinal surgeon to avoid any bowel injury is particularly relevant in these patients. Evaluation of peritoneal adhesions may be feasible on routine CT or MR, the study done for assessment of the primary disease process. Peritoneal adhesions may be detected apart from the primary disease process in the same study without any additional cost, radiations, or side effects to the patient. Peritoneal adhesions may be evaluated in terms of morphology, extent, and quantification. The effect of adhesions over abdominal wall and visceral structures can be better delineated as compared to the direct visualization of the adhesion. The findings in these imaging modalities are likely to correlate with laparoscopy to varying extent, depending upon type and location of the adhesion, also on the secondary effect of the adjoining structures. Pre-op CT and MRI studies have been potential to serve as the non-invasive surgical roadmap for the operative interventions and laparoscopic procedures. Imaging diagnosis of peritoneal adhesion is also clinically relevant to the established cause of patient symptoms, mainly in patients with chronic pelvic pain. CT and MRI diagnosis of peritoneal adhesion may help in deciding operative approach, may facilitate precise preoperative planning. Preoperative CT or MRI for the evaluation of peritoneal adhesions particularly makes sense in present era of evidence-based clinical practice, as they provide objective evidence to justify the need for surgical adhesiolysis. Adhesions, peritoneal adhesions, pathophysiology, 4 insults, injury, ischemia, infections, and the irritation. Macrophage-related chemical messengers forms fibrinogen matrix, then adhesion, maturation process, cellularization. And there are 2 types of adhesions, enteroenteric and enteroparietal. Enteroenteric adhesions, risk of bowel injury is there, and small bowel obstruction it causes. And enteroparietal infertility, chronic abdominal pain, increasing operating time. How it looks, normal anatomy. This is bladder, this is vesico-uterine pouch, this is recto-uterine pouch, this is the uterus, and same on the laparoscopy. Peritoneal cavity, normal anatomy. This is anterior abdominal wall, this is subcutaneous fat plane, this is bladder, uterus, and rectum. And properitoneal fat line is seen very clearly on MR as well as CT. Now, peritoneal adhesion, this is obscuration of the properitoneal fat line on CT images, considering that there are adhesions. And these are lateral enteroparietal adhesion, which connects between the abdominal wall as well as the bowel. Peritoneal adhesions, this uterine adhesions, anteriorly the uterus is elongated and adhered anteriorly to the uterus. There is elongation or increased uterocervical length seen on the image. Peritoneal adhesion, there is a loss of recto-uterine pouch, which is obliterated here. Deep pelvic adhesion, there is a band between the small bowel as well as the cyst in the right ovary, confirmed on laparoscopy here. Deep pelvic adhesions, the couple of endometrixes attached to the ovary and that attached with each other. These are the band adhesion responsible for the bowel obstruction, and on left side these are matted together causing obstruction. Loculated intraperitoneal fluid adhesions, and the ovaries are entrapped between this fluid collection, and these are the adhesions. There is one scoring system based on this. It includes status of anterior abdominal wall, second status of the peritoneal cavity, third status of the peritoneal fat and the fluid. And scoring system, if it's normal, 0, thin flimsy adhesions 1, thick more than 2 millimeter adhesions 2, and contour deforming adhesion 3, status of peritoneal fat and fluid, focal linear fat sending 3, and fluid loculations 3. Take-home message, ultrasound is good enough for preoperative assessment and surgical planning. CT and MRI are useful for diagnosing peritoneal adhesions and related importance for the deciding route of the hysterectomy. Thank you so much.
Thank you, sir. It was a very beautiful images of 3D MRI and CT scan. You have wholly described each and every conditions of a gynecologist who can know, and it was very nice lecture. Thank you. Yes. Any questions? Beauty with brains is a perfect description of our next speaker. Yes, she is none other than our own Dr. Anjali Chitnis, madam. Madam has done her undergraduate and post-graduation from GS Medical College and Wadia Hospital, Mumbai. She is honorary professor in OBGY department at Dr. VM Medical College, Solapur. HOD Markande Sahakari Hospital, Solapur. Postgraduate and undergraduate teacher, gold medal and fellowship in Mumbai University and in MBBS. She was a past president of AMOGS. At that time, we had seen her leadership qualities. There is a lot, her special areas of interest I would like to mention. First is NDVH, emergency obstetrics, perinatology, traveling, good collections of sarees, and to create positivity amongst SOGS. Over to you, madam. Madam is going to talk on evolution in NDVH as I witnessed and experienced.
Good morning, everybody. It's coming back to your own home, own society. I congratulate and thank Dr. Virkar. He gave me this opportunity, all the organizers. I remember Virkar as my lecturer, calm, quiet, very well thinking power and decision making. Once it was inversion of uterus, he said, "Madam, there is inversion." I said, "You start dealing with the patient, I'll be there in another 5 minutes." By the time I came there, everything was reduced. So that is Virkar. He didn't utter anything, no tension, nothing, and he did everything. So that is how I remember Dr. Virkar. The society, I am very happy with this academic activity of the society. It's my child, because way back in 80s when I finished my PGs and lectureship, I came back to Solapur, and with all the bombarding suggestions of Dr. B.N. Purandare, Dr. R.D. Pandit and all these, we started the society here. And today I can see all my kids here with the society so much academically gone to the peak level, I can say. That is good academic activities, there is good correlation, there is good communication between each other. I am very happy. What else? I don't think I need anything else from the society. So now coming to the point is hysterectomy. The new name NDVH, we never used to call it NDVH, because now let me tell you that I devote this lecture of vaginal hysterectomy always to my teacher, Dr. B.N. Purandare, from whom I learned the practice, art and science of medicine, observing the craft of performing original undescended vaginal hysterectomy. Each word is very important. The craft, original, it was not a new NDVH, it is original undescended vaginal hysterectomy, which we used to do at Nauroji Wadia, Parel, and way back with Dr. Mr. Somaiya, the businessman, where they have taken us to most of the remote places, and we learned vaginal hysterectomy there. Now this slide we'll just skip. See, the way to a woman's uterus is always through vagina. Nothing else. There's no other route to approach vagina. Examination and operation. Do you think the tonsillectomy operation can be done with a cut on the throat? No. It's you go inside and they remove the tonsils. Then why should we have a cut on the abdomen when we have vagina and direct approach to the uterus? So that is how the thinking of vaginal hysterectomy goes very much from the beginning. This was around 70s and 80s when I was a lecturer and the houseman lecturer registrar. So these people used to do it before that also. Vaginal hysterectomies at that time were classified like vaginal hysterectomy, which is now called as NDVH. Vaginal hysterectomy with AP repair, that is for first and second degree of prolapse, where you do vaginal hysterectomy where the cervix is very much inside the vagina, and you do AP repair where there is a slight cystocele rectocele. And the third was Mayo-Watts hysterectomy, where there was a third degree prolapse or a procedentia, and you do hysterectomy and you go ahead with all different repairs like a Watts stitch, like a Kelly stitch, and all other stitches. So those were the three different types of vaginal hysterectomy we used to describe. The indications were very different at that time. The contraindications we learn at time have become indications of vaginal hysterectomy now. So there is a gross change, or there is an evolution, improvement in the process of NDVH. See the saying, we consider extirpation of the uterus not previously protruded or inverted one of the most cruel and unfeasible operation by the head or hand of man. This was in 1825. But AD 120, Hippocrates described amputation of uterus vaginally. Maybe this must be a prolapse uterus. 11th century, 15th century, 1560, 1600, there was vaginal hysterectomy. Probably this was a prolapse uterus and vaginal hysterectomy was done. This was done by midwives, the surgeons, or sometimes the patient herself used to amputate the prolapsed cervix. The mortality was very high at that time because of bleeding, because of infections and all these things. So the scientists or the stalwarts, these were mainly the surgeons, they started thinking for the improvement. And how did they improve? Slowly they started artificially prolapsing the uterus on table. Like they used to pull out the uterus and cutting the appendages. This was started for uterine cancer. Broad ligament was identified then because there was gross bleeding. The vessels in the broad ligament were identified and they started ligating the vessels. So ligating the vessels for prevention of bleeding. Vaginal hysterectomy was done before first abdominal hysterectomy was done by Clay in 1843, where mortality was very high. These are different surgeons who used to do all these procedures, modify the procedures, and they used to keep on thinking. This is Kelly, which stitch we always put. The French, the Arabs, and everybody started. They started opening the cul-de-sac. The first thing, they opened the posterior pouch, but Doderlin thought that it is better to improve by cutting the anterior pouch. Then they started opening the anterior pouch. In 1894, vertical and oblique morcellation of the uterus was done. This was to reduce the size of the uterus. Till this, surgeons were in charge. Even now at some places, surgeons are in charge. You know, they have that approaching over the gynecologist, thinking that gynecologist is a very minor branch and they hardly know anything. So surgeons used to do it. But in 19th century, gynecology was identified as a specialized branch. Vaginal hysterectomy technique was systematically studied and developed by, all these professors and all these people, we read it in our books, Sims, Werdams, Schauter, Kelly, Bonney, Mayo, Meek. So they all contributed to the vaginal hysterectomy. I am saying vaginal hysterectomy is our NDH today. Understanding now how they improved. They wanted to improve understanding the physiology, pathology of the reproductive organs. The anatomy is also very important. You have to know the anatomy, you have to know the physiology, and you have to know the pathology. What is wrong with the uterus that we are taking it out? The clinical manifestation of the disease study, like now Dr. Meru said about everything about the diseases. The blood transfusions at that time, now we hardly need any blood transfusion, antibiotic, anesthesia, proper indication and contraindication to the vaginal route were studied very much at that time. I remember when we were in the camp, Dr. B.N. Purandare used to say, why you want to do PV before starting the operation? Put your hand on the abdomen. If it is palpable, go ahead with abdominal. If it is not palpable, go ahead with vaginal hysterectomy. Normal and abnormal psychological and sexual development of the patient is very important. See, you have to judge whether the patient is going, and she should know that she is going for vaginal route. Because sometimes if they insist for abdominal route and you go for vaginal route, all the post-op day 1, 2 till she leaves you and goes to another doctor, she will complain of there is something painful, this about vagina. So you have to explain the patient and you have to consider her psychological and sexual demands and the needs of the patient. He started operating, Verdams and all these operated for cervical cancer. This was done vaginally. Shauta did it radical vaginal hysterectomy with extraperitoneal lymphadenectomy. This is vaginal without prolapse and without anything, undescended. End of 19th century and early 20th century, instruments were modified, anesthesia, antisepsis, and the mortality rate came down very much. This is just a picture I wanted to show you, because see how many surgeons or how many maybe gynecologists are there and they are discussing the patient and the case and the ways to proceed abdominally, vaginally or whatever. So this is very important. Discussion, decision, consultation, communication is very important before you go ahead with the case. Now what did we Indians do? Not we, but our teachers, they were stalwarts in gynecology from India. They returned back from UK, Germany and Vienna with great training, degrees and experience. They were Dr. B.N. Purandare, younger brother Dr. V.N. Purandare, Mitra Subodh, N.N. Roy Chowdhury, V.N. Purandare and C.G. Saraya, and most important is Dr. Shirodkar. So they were the stalwarts, the pillars of vaginal hysterectomy. This is Dr. B.N. Purandare. B.N. Purandare was a student of Victor Bonney, Sir John Pill and Professor Novaroti. It was B.N. Purandare's surgery, vaginal hysterectomy, NDVH, at that time was described as a physiological operation. See, his operation was so clean and so perfect that it was like a physiological operation taking out the uterus vaginally. No blood, no mobs, no clamps, no tissue mess. See, each word is very important. We used to see his mobs, the mobs used to get stained, like there were 1 or 2, 3 bleeding spots. It was never another mob, was impossible. He used to open the anterior pouch. He used to teach us that anterior, when you take an incision, transverse incision, it should be with the weight of the knife so that you exactly cut the vagina. If it is less, you don't cut the vagina. If it is deep, you go through the cervix and then your planes which you are going to dissect anteriorly, they get lost. So the weight of the knife is very important. Once you open this, there is an anterior retractor. You have a traction on the cervix and the pouch starts, the vagina starts going back easily and you can go in the proper plane and it's easy dissection anteriorly. He used to use ligature method. His long fingers used to hold the ligature and he used to ligate. So they were hardly, like when we went for camps, he used to give us a small rectangular box. There were 2 retractors, 1 valsalum, artery, and 1 coccus he used to keep for junior people in case the ligature slips. Needle holder and forceps. That was the instrument, these were the instruments for this hysterectomy. He used to say, movements of finger, like opening the pouches, the feel of the tissue, knowledge of anatomy, like pillars of the bladder. Where are the pillars? Where are the bleeders which supply? Don't cut, push them. So, and the surgeon's confidence, which are very, very important, was his saying. Then Dr. V.N. Purandare, the younger brother, he started using saline. He injected saline so as to reduce the bleeding, and he used to get good levels of the anterior and posterior spaces. He started using clamps. He started removing the adnexa. He did Shauta's operation. Subodh Mitra and N.N. Roy Chowdhury extended radical vaginal hysterectomy with extraperineal lymphadenectomy. Dr. Kamal Sathe, I am very proud to tell you that Dr. Kamal Sathe from Solapur was a student of Dr. B.N. Purandare, and she was the first person to come down to Solapur and started doing undescended vaginal hysterectomy. This is Dr. Mitra on this side, and V.N. Shirodkar, to because we have his oration. Now me as a student, there's nothing, we learnt all these procedures from these stalwarts. I was very lucky to be with them. 5 hysterectomies you have to see from behind. 5 hysterectomies you have to assist. 5 hysterectomies you have to sit, some senior person, or when he had time in the camps, he used to come and assist us and teach her the feel of the tissue, the area or the exact position of the clamps. This is how we learn vaginal hysterectomy, and we started doing vaginal hysterectomy way back when I passed my MD and I started doing my post-graduation. So it was a vaginal hysterectomy. Later on also I started my practice and started doing, because I was used to this NDVH very much, number 1. Number 2, all positive points of NDVH were there. Number 3, I was little lazy to do abdominal hysterectomy, like open up the abdomen and then close the abdomen. So it was easy, you sit down and just do it and finish it off. So I was really lucky to do all these vaginal hysterectomies. The laparoscope came in 60s and 17 onwards. They say, the Foxy president says that laparoscope is a glamorous surgery. I really believe it's a glamorous surgery. You see so many instruments, lights and this and that and all this thing. I don't do it much. So it's a glamorous surgery. So they started doing LAVH, scopy with a vaginal hysterectomy. The incidence at that time of vaginal hysterectomy reduced prominently, and laparoscopy had become very popular. Expanding vaginal hysterectomy again, like they combined all these hysterectomies together. Then came Dr. Shirish Sheth, who was a student of Dr. B.N. Purandare. He was our teacher, so he was very senior. He started doing it for bulky uterus, fibroid uterus, previous LSCS, adnexal pathology, nulliparous patients, malignancies, and resection of the lymph node. And he labeled it as NDVH, non-descent vaginal hysterectomy. Then there were many newer expansion. Like I want to add Dr. Kavita's name in this, who says she's changing MDVH to MIVH, minimum invasive vaginal hysterectomy. So next time, I'm not going to give this lecture again, but if at all I get a chance, I'm going to put her name here, and after Shirish Sheth, she'll be there to do all these things. So newer expansion, I'm not going to tell you in detail because there are many people who are going to talk about myomectomy, abdominal episode. I did vaginal hysterectomies, but I never crossed beyond 12 to 14 weeks. It was 14 weeks was our limit. If it is more than 14 weeks, just open the abdomen, transverse incision, remove with the screws and all these things we just used to remove. Gynecological episiotomies, if the nulliparous patients, when the vagina is very narrow, you have very less space to go and operate inside, cut it points, and he decided to do a 10-step vaginal hysterectomy. Ultimately, it's the same what we do. Now here I would like to show you, there are methods of clamping. There were methods, there are methods now, and there will be many methods even afterwards. See, what I used to do, because I learned everything from Dr. B.N. Purandare. What we used to do, the way this clamp is there, this clamp they have put over here, we used to hook the ligament with our index finger. Just hook it by, with your index finger, whole of the ligament or whatever, the uterine or the upper cornuals, and you take a stitch, tie the stitch, hold the stitch and cut it. So this is called as ligature method, which was very much in practice. Later on came the clamp method. This was the clamp method. Applying the clamp is also an ideal thing, or it also has got some principle, like which ligaments you have to apply oblique clamps, which ligaments or which tissue you have to go ahead with vertical application. So direction of the clamps are very important. Clamps themselves are very important. See, every year you go for conferences, just keep on buying 2 good Cockers clamps, because clamps, you have to take care of the clamps, because clamps have to be very firm and very good. So every time you go for conferences, don't go for sari centers, go for, I used to do this before buying saris. So I used to buy 2 clamps every year. Buy a Mayo Caesar. It's very important to buy new Caesar every year if you are doing vaginal hysterectomies, because the cut with the scissors is very important. You know, you can't keep on digging and cutting. You have to have a sharp cut with the scissors. Those scissors, needle holders and 2 clamps every year. Change it, buy a new one, which is very important. Then came all Gurram's methods, you know, like cautery and harmonic, and I don't know what all things he do, but he is doing so many things. And every time he tells me, madam, you come and see what, and you also start doing. I never did it, but I used to, you know, it was very nice to watch him doing it. So that he will tell you. So these are the different methods of clamps. Again, little bit about pouches, you know, the anterior. We used to open the anterior pouch first, because in undescended, there is no descent, so you can't pull out the fundus of the uterus from the posterior pouch. In prolapse, it's easy to pull it out, but in undescended, it's way high up, and you can't pull it from below. So you have to open the anterior pouch. Anterior pouch opening, I told you, the weight of the knife, and then you push it up, the retractor retracts, and you go above, and you have to feel the tissue. This is bladder, this is peritoneum, this is the fascia in between, and then you open the anterior pouch. If not, go ahead with posterior pouch, open the posterior pouch, ligate the uterosacrals. Even then it is not easy for you, or you are not confident to open the anterior pouch, go ahead with uterines also, extraperitoneal, you can ligate the uterines and go ahead and cut the uterines, and then the pouch comes in your hand. And so then you open the, start doing the hysterectomy. So this is very important. Little bit confident you have to be there while tying the uterines. The uterines, I still tie the uterines twice. It's better, you can go home and sleep peacefully. So tie the uterines twice, tie the cornuals, transfix the cornual at the round ligament and transfix and do 2 sutures. Baki rest of the thing you can have 1 suture. Anchoring of the vagina, if you want to prevent walled prolapse, is very important in these cases, even if it is undescended, but there may be laxity as the age advances, so you have to go ahead with anchoring the vagina to the ligaments. There are many different stitches. There is Heaney's technique, there is Watt's technique, there are many different techniques. You get used to some of the technique, or you can modify yourself and do it, but anchoring is very important. We used to tie the peritoneum with purse string. Later on, not because of the recent advances, but because of my advancing age, I stopped tying the peritoneum, taking a purse string suture, because I was feeling a little lazy. And then you do closure of the vagina. Closure of the vagina again with a continuous locking. I take interrupted so that there is space in between for the drainage of the collection inside. So I used to take interrupted. So these are all about the minor points of hysterectomy. This is opening the posterior. These are things in the 10-step hysterectomy. So instruments are very important. I used to take stay suture on the cervix. Now you have got very good valsellums, tenaculums which are very strong, so you can use those. Then will come the robotic. It has already come in 2005. This will not replace the surgery but enhance their performance. FDA has approved this, either robotic or robotic assisted hysterectomy. AI, artificial intelligence, will tell you whether you should proceed easily, whether your procedure will be an easy one or you will have problem at certain levels. That will come in another maybe next 2-3 years, and the president will take, there is a recent advances about artificial intelligence. He'll make me sit in one corner and there will be another speaker talking on artificial intelligence. This is about robotics. This is a pyramid. I don't think it's a big, but this is a very good pyramid of successful practice in gynecology. This is a very important thing. Hysterectomy is relatively easy operation to perform and is often easiest when least necessary. This is very important. Small erosion? No, this patient needs hysterectomy. This is the easiest hysterectomy, easiest vaginal NDVH you can say, because it's not indicated. There is no pathology inside. The uterus and the cervix doesn't need to become doesn't need to be out. Then AUB, 1 bout, 2 bouts of AUB, no trial with the medical treatment, nothing. This patient needs hysterectomy. This will be another easiest. So this is easiest when it is least required. So coming back to the summary, at the end of this is also very interesting part. At the end of 1980, this is older, this thing, a California woman only had 50% chance of going to her grave still in possession of her uterus. I feel around Solapur there are places where patients, they don't have uterus at all. One must be familiar to all the techniques. This is very important. This is going to be a very discussing, fighting point for the panel discussion. Because it's not, see, I am not Guram and I am not Kavita to do 24 hours, 24 week size fibroid hysterectomy. So I should know my limits. I should know what I can do. And I will do accordingly, do it accordingly. Don't think that he is doing, so I have to. There are limitations. You have your own limitations. You are dealing with a patient. You can't say 24 week size uterus. Yes, in the conference it was discussed that you can remove. No. I personally will not suggest, if it is 14 weeks, go ahead and do it. But more than 14 weeks, at least refer the patient to Dr. Gurram, let him do it in a proper way. That is what I feel. So another thing is you must be familiar to all the techniques. Anytime, sometimes the vaginal hysterectomy, you have to discontinue and shift to abdominal. So you should know abdominal, you should know vaginal, you should know how a laparoscopist is going to assist you when you are doing a hysterectomy. So one must be familiar to all the techniques. One cannot replace another. If it is 24, 30 week size uterus, I will not go vaginally. See, I had seen one doctor doing 24, 28 week size fibroid, 28, very obese patient, so it was missed totally, right up to the umbilicus, nulliparous patient, and we discussed my relative, that was my relative. And we discussed, and I said, I'll go per abdominally. I'll open with transverse incision with a screw and all, I'll remove the fat. No, said we'll go with laparoscopy. And the patients have not that glamour. So it's a glamorous surgery. Patients very happy. One puncture, eka टाक्यामध्ये everything is over. So they are very happy. So she agreed for laparoscopy. He started at 12 o'clock. This is a fact. I was there in the theater. He started at 12 o'clock. He finished his removal of fibroid, because she is nulliparous young patient, at 10 o'clock in the night. So from 12 o'clock in the afternoon, 10 o'clock in the night, the surgery was going on. I will not advocate this surgery. I will say, you better open up and remove. He removed the fibroid. He opened up the cervix by mistake. So cervix was open at the level of the isthmus. So her obstetric career is gone. And this is how it went up. I will not advise you to the young generation. Don't go that, yes, this is this, this is this. No, this is patient, and this is, we are dealing, and patients are not machines. They are human beings. Each person is different from another. Procedures you have to modify according to the patient, according to your own confidence. Hysterectomy is relatively easy operation to perform and often easiest when least necessary. Mastering the art of vaginal surgery is an art itself. Looking at B.N. Purandare's vaginal surgery, everybody, that was a dictum at that time, that B.N. can remove thyroid also from vagina. This was the dictum at that time, that his surgery was so, it was a craft. Like there is Shivan and Kashida madhe there is difference. You know, Shivan is anything, machine mala, that's Shivan. But Kashida is different. So his surgery was like that. So try and learn that surgery. Try and learn the proper indication of the surgery. Do lot of practices. I remember I was talking with Swati. She was my house surgeon in Vadia. Vadia was a private institute. So I said, you want to do vaginal hysterectomy undescended? Do it today. Tomorrow you will do my case. It was a private hospital, mind you. But you have to read completely and come. Then only I'll give you surgery. Next day morning I asked, have you read? She said, no, I have not read. I said, you are not going to do the hysterectomy. Postpone the case, read it, tell me and do it. So study of the patient, study of her situation, anatomy, physiology, pathology, disease, whatever possible. Now to you have got plenty of ways to find out what is wrong with the patient and do the surgery. Movements of fingers. The last thing is take home message from me. Movements of your fingers. Feel of the tissue. Knowledge of the anatomy and surgeon's confidence is what you need while going ahead. Even if years go by, new techniques come, but this remains at the same point. Thank you very much for listening the fairy tale stories from 70 onwards till today. And we'll discuss rest of the thing in panel discussion where I want to fight with the younger generation. Okay, thank you.
Hello. Our age, everybody has experienced doing a vaginal hysterectomy was a great thing. And what you had just told us, that limit yourself when you know how much to do it, how to learn the art of doing a vaginal surgery, and how much you should know the limitations of the doing a surgery. It was an excellent presentation. We enjoyed a lot. Thank you. Now we are moving to a very interesting lecture by Dr. Kavita Bapat. Just now Dr. Anjali Chitnis has told us not to dare to do a hysterectomy after 12 to 14 weeks of the uterus. Here we are to learn and to have a daring to do a hysterectomy after 14 weeks of the size of the uterus. I just want to introduce Dr. Kavita Bapat, who was the Vice President of FOXI 21-22. She was organizing secretary AICOG 22 Indore. A little. Then director of the Bapat Hospital at Indore. She was the chairperson and in various committees in the FOXY, and she has been have a lot of other paper presentations and having good positions in the different societies. And here she is there to guide us and to give us a lot of confidence to do a surgery beyond 14 weeks of the uterus.
Thank you so much.
Thank you, madam.
Thank you so much. It's open. Okay. Light कमी करना है नहीं होना. Hey, thank you so much for first of all Dr. Virkar for inviting me and being a persistent and confident about me that I have to come to Solapur. I am really blessed. I am really blessed. Hey, चालू करा ना. It's open. Yeah. Lights off. So thank you Solapur Society for giving me the chance to come to this place. My geography was little bad though, that otherwise me आणखीन 2-4 societies केल्या. So being a presidential candidate and traveling all over India and talking many more things all the time, this is one of the topic which I am talking nowadays. So 20 weeks, uterus and what I am doing. Tell you, my first manifesto as being a president of FOXY is save the uterus. So thank you so much, Anjali madam, for giving us the chance that this is the real priority of this country. We have to save the uterus by not doing or by doing the indicated hysterectomy. That's our real right and that's we should do. What I am talking, the dare and all those things and the techniques and all those things which we do, it's all the things, but in heart of heart, that this is the one point and another manifesto which I am going to put it out in a way. It's very soon I am going to have it. The person from Solapur or a person from Shajapur, a person from Solan or a person from Salem, everybody has right to become the president of FOXY. It's not the point of few areas and a regionalism it has been taken. So these 2 points, I started with the thing because it's very, very important that every FOXian has got the chance and every member matters. So this topic, which is really, I love this topic and all glorious journey, along with your point, which as you have talked about, I am very well known about my Learn Simply series. All over India, people read my Learn Simply series. There are more than 50 volumes. Today was the 50th volume, which I have just told, and if people like to read it, it's a small, precise one. If Solapur Society have not received those volumes, I'll post it and they can see it. So it's a very simple learning, and I always, my subject is also very simple learning. A student just passed from MS can do vaginal hysterectomy early, then all I think this is the place where people are very much are doing vaginal hysterectomy because of the Chitnis madam, because of the Guram sir and all the people. So I think the Solapur mein to vaginal hysterectomy ke baare mein bolna matlab something is ridiculous. But still, so this is the point, all the glorious journey. So what exactly, what our patient wants, that's very, very important in our life. It's not like that whatever we do, whatever we design, whatever we do the things, it should not be like that the show off that main 20 weeks ke size ki uterus kar leti hu. So there are the rules which we should follow. Number 1, treat our patients as queens. Number 2 rule, which I always love to talk about, spread ideas and move the gynecologist. See, the thing should be in a mind that what we are doing. Number 3 is help them, see them, what you are saying. I think the Dr. Chitnis is a very good example for this. Then the practice design, not a decoration. That's another big point. And 5th rule, which we should follow about, we should have cultivate the healthy relationship between each other, like you and me, with our patient, with our colleagues, with our seniors, with our juniors, when we talk about them. So if I can do no good, do not harm, this is really the principle of Hippocrates, and choice should be the one that is the patient's advantage. For example, if I'll have a 16-week size uterus to my daughter, or my brother's wife, or my close sister, or my mother, am I going to do it vaginally? That should be the first question. If I am ready to do on them, I should be ready to do it with my patients. Am I right? Because without that, because this is a rule, if I am ready to do things on my own people, then I am supposed to do with it. So the dare is maybe the word. It may be a little show off, but I am telling you, if one person is so much experienced and doing so many things, can do many more things. So I'll take you to some few points with the more than 500,000 hysterectomies per year, and we are all doing for fibroids, for bleeding, for endometriosis, and a pelvic pain, and significant cost to the healthcare system. By age of 60, 1 in 3 women. I think Dr. Chitnis has said very nicely कि अपने यहाँ तो दफनाते नहीं है, पर यदि जलाई जाती औरतों में भी देखा जाए तो विल सी आपल्याला कळेल की uterus is not there. So this is another point is there. Then this is 1 in 3. This is real not good or bad, I don't know. Now why we are shifting ourselves from the conventional surgeries to the minimal invasive surgery. I call my hysterectomy is a minimal invasive vaginal hysterectomy. So see, when we were students 30-35 years back, to assist someone in a vaginal hysterectomy used to be the most nauseating thing and most worst thing of things. मेरे को लगता है वो instead of learning we thought कि we will not do the vaginal hysterectomy 30 years back. What I am saying, because the suturing techniques, lot many things, and the assistance for 2 to 3 hours. If you are on the right side or in the left side or in the back of the surgeon, it's a 2 to 3 hours. It's such a terrible pain on the neck. So that was one thing. Another, I don't know, you must have seen or not. In our place at Gwalior, they used to have threads to suture the ligaments and whatnot. And the amount of pus used to come after the vaginal hysterectomy, God knows, because they're not good antibiotics at that time and many more things. So the dressing. So one consultant over there, she used to do the vaginal hysterectomy, and I think this was the disheartening कि आगे जाके हम vaginal surgery will we follow or not. But the time has changed and the minimal invasive surgeries, because we all also have all the rights, like all sitting over here. We can use the harmonic, we can use the electrocautery, we can use the vessel sealer, we can use the morcellator, we can use anything through vagina. So why we are not able to do minimal invasive vaginal surgeries through the right route, which always talk about. So conventional surgeries and a minimal invasive surgeries, and all the business is changing towards the minimal invasive surgeries. Now these are the hot businesses in the world. Number one is the hot businesses is the child care service, which everybody talks about. Everybody sitting over here having at least 4 or 5 mobile apps on their phone. We all our lives dependent on the mobile apps. Number third point is all the mobile gourmet food. We love to bring the food. We used to tease our kids, but the time has come, we also do the same. We bring the food in the thing. Then the brain games. Most of the time there are some or the other game was installed on our phones and we play that game. Then another very, very important destination, wedding. I had been to Udaipur and I just started saying that I come up from a place which is very clean or something. I said like that because I come from Indore. They were not happy to listen. They say we are a place, we are the most romantic place in the India. So most destination weddings happen in some places. So this is also in a fashion. So what I'm saying, these are in a fashion. And the last and most important fashion is minimal invasive surgeries. Why I said it, not into the OBGYN, not into the anything like that. It is more common in every branch. You see the orthopedics, they do the minimal invasive. So you see the ENT, they put through the nose and go to the base of the day, they put the scope into it, all minimal invasive. Even the minimal invasive surgeries into the ophthalmology, into the neurology, into the orthopedics, into EAD, you name the subject, the gastroenterologist, the urologist. So why not we as being a gynecologist, minimal invasive surgery? So don't take it in a two-way. Laparoscopic surgery is also minimal invasive surgery, but going through vagina, minimal invasive surgeries has got the role. So surprisingly, this is the point, and the robotic surgery hardly very costly, laparoscopic surgery, conventional surgery is taking change, and minimal invasive surgery is the most cost effective to the points. And these are the demographic factors, the recovering economics, and the innovative ideas will bring and will change everything. So evolution, I just love the Chitnis Madam's lecture about the evolution, so I'm not going into it. And she talked and told everything nicely, but the minimal invasive surgery has got the rules. Now what is the goal? Can I do 20-week size uterus? This is the really very, very important point. I should ask the question to myself, and then talk about. So what should be the new selection criteria for doing surgeries? Selection criteria depends upon person to person. It's not like that a person who has just passed masters and doing practice for last 5 years, or person who is doing 10 years. The selection criteria will be different, but still they should be very, very academic. They should have some guidelines and then they should do it. Then what are the techniques? Like Dr. Gurram is using the electrocautery. I use the electrocautery. He is using a different manner. So we should know the technique. Then the fun is very, very important. If I'm not happy to travel from North India to South India as a contesting for the President Foxy and not having fun, taking a serious face and moving here and there is no use of my campaigning or anything. Like similar with the surgery. If I'm planning to do surgery, my fun should be there. Then what new instruments which we can use in our insisting, and most important, what are the challenges? Am I able to cross my challenges? Am I able to take my challenges are another important thing. So these are the hot sprints, and we all talked about several times. Whenever the topic of vaginal hysterectomy, ये 4 points सब लोग बोलते हैं. Everybody, प्रत्येक मानुस बोलते हैं 4 point. Number is best favorite procedure, developed in the past, need not to be the procedure of the past, and we cannot allow it to die. Because with simple 2 speculum, 2 valcellum, with 2 cockers, we can do many miracles through vagina. So again, we are trained into vaginal surgery and this. So why we are changing our everything into this era about the minimal invasive surgeries, and why we are talking about the daycare surgeries, and why we are able to do many things because of the evolution of electrosurgery. Previously, when we used monopolar instrumentation, then conventional bipolar instrumentation, now we have the advanced bipolar instrumentation. We have the vessel sealer, we have the bipolar cutting, tissue impedance feedback, we have improved outcome into the terms of tissue effect, and there is an improved bipolar disease. This is a very important, and has given a different change the scenario of everything. Now what are the general principles of the surgery when we use the minimal invasive instrument? There are 3 new principles, only 2 instruments, application of clamps close to the uterus, and there is a no traction. That's the 3 things. These 4 things are very, very important, because principles are we don't need much instruments, the clamp should be closer to the uterus, and traction is not needed. So these are the technical challenges when we have the learning about the doing surgeries. Number 1 is exposure. Number 2 is hemostasis, entry into the cul-de-sac, large uterus, and urethral injury and high head neck side. I travel a lot. I was being asked if I want to be a obstetrician and gynecologist for next life. I said I love to become obstetrician and gynecologist for next 100 lives. We all love. I think everybody will agree. But I'll ask Bhagwan se मैं 4 वरदान लूँगी. Only 4 vardhan I need to become this. Number 1 vardhan I need from the God is how much lateral I go, I should not touch the ureter. Am I right? This vardhan I need. Then the second vardhan which I need from the God, whenever the patient of PPH, the placenta accreta, septum, everything when comes, I should be able to save mother, baby, and myself. That's the third point is very, very important. Number 3rd point is, whenever the patient of recurrent pregnancy loss come, I agree, everybody will agree with me, that's the patient, they leave us maximum. Once the pregnancy loss, she leaves you, she goes to her, she goes to him, and she goes to. So whenever the recurrent pregnancy loss patient comes, I should be able to give the baby to them. Am I right? If this vardhan is there. And the 4th, the moment the patient enters into my chamber, I should be able to diagnose her or any cancer without putting much more intervention. These 4 vardhan, I think everybody will agree to become OBGYN for next 100 years. So that's a big point. So urethral injury, you just remember, we need something, somewhere to help us out. Then, see, this is the difference between the previously we do the classical surgery and what is the, when we use the vessel sealer. See, the number 1 classical surgery, we used to put the clamp, we severed the pedicle and using the scissors, then placing the sutures with needle holder, then knotting, then removal of the forceps, then cutting the suture with the scissors, and this is very important. But when we started using the thermal hemostasis, we need only 3 steps. 1, positioning of the clamp. removal of the clamp and cutting with the scissors. So we are saving the time because we are not using all the sutures, everything, and thermal hemostasis is there. There are accidents which happen with the thermal hemostasis, and we should be worried about the burn, the necrosis of the ureters, the thermal of the wounds of the digestive tracts, bleeding immediate and secondary, and infection. So this is the ligature vessel system which has come. I think Dr. Gurram is the best person. Whenever I have to make some online courses or I have to make some group where I am supposed to call many people, many students listen, the Gurram sir is the best to talk about the electric part of this thing, and I think everybody knows about it. So low voltage, high current, independence, and why I am talking when we are talking about 20-week size of uterus and what I am talking? Because this is the preliminary for everything if I am doing the big uterus, and this is the vessels, flattening, thermal dehydration of the tissue. Now these are the benefits of the tissue fusion system, consistent and control energy. It's had the reduced thermal spread, and there is a least charring, I'm sorry for this sticking, and there is zones are more flexible. These are very, very important. Now what are the sequence of impression? Like you said, Dr. Chitnis madam said about the 10 steps about this. Nowadays we say the uterus can be removed in 6 steps. Am I right, Dr. Gurram? This only simple 6 steps. Vaginal circumferential incision around the cervix, opening of posterior peritoneum, opening of anterior peritoneum, clamping and cutting of ligaments, clamping and cutting of uterine vessels, amputation of the uterus, and occlusion of the uterine walls. Can I see the video? Chalega ye? Volume aa raha hai? Without putting anything, no hydro, nothing, just give a single monopolar cautery, give a circumferential incision all around. If it is done at the right plane, nothing will happen. This is the first step. Agla jayega. This is the second step, opening of posterior peritoneum. I just appreciate the Dr. Chitnis' word, the movement of the fingers, knowledge of anatomy, and though or pointer which I'll use next time. Chitnis madam, all 4 points were good. So the use of fingers are very, very important. That's another thing, opening up. There is no bleeding if we know the anatomy and if we know where to enter into it. It's, I think, volume. So the opening of posterior peritoneum first, then opening of anterior peritoneum. Correct and great scissors, right plane dissections. If you are in the right plane, there will be no bleeding. If you are not into the right plane, all the problem starts. Another thing is very good assistant is needed and very good light source over there is needed. This is the third step, I think. Then the clamping and cutting. Again, you can see the hardly any bleeding anywhere if we are in a right plane. Why the problem comes? Because we are not at the right plane, we are not in the right position, we are not into this thing. So the uterosacrals, McEnrods on one side, uterosacrals and the McEnrods on the second side. Same on the other side. Then, after removing the uterus, occlusion of the vaginal wall, it should be done vertically. The whole world is changing. There is having a big things about just close it vertically. See, hardly bleeding, no infiltration, nor epinephrine, and the BP of the patient is also good. Don't worry about that. Ki shayad BP nahi hoga. No, the BP is also there. So I think next is, so now, I'm so thankful in the morning that Dr. Veeru, he talked so good about the sonography. So 20 weeks uterus and what is our role into the sonography. It's very, very important. If I am not assessing, now I have in the first part of mine was about the minimal invasive surgery. Now I am talking about the why to do and what to do about the 20-week size of that. The role of ultrasonography is so important and you have done in such a nice manner. Everyone, before doing the surgery, we should know what is the volume of the uterus. The normal uterine volume, 30 to 60. The postmenopausal uterus volume is less than 30. 285 volume for the 12-week size of the uterus, and when the volume is more than 240 to 350, it's more than 14-16 weeks size of dens. Now these are the areas, and I think we have learned so much good, but for general OBGYN, these things they should know. They know that this is a shaded area and we should know the 3 dimensions of the uterus. A little mathematics by each one, humko sirf sonologist pe dependent nahi rehna hai. We also know what is the volume, and the volume is calculated by 3 dimensions including length, the width, and there is a simple form, and the anteroposterior diameter. And don't go into this prolet ellipsoid formula which looks very horrible, but it's not that horrible. Just to simplify the formula, just multiplying the length and the breadth and the AP dimension by 0.542. It's very, very important, and get the volume of the thing. Simple thing, and the volume is very important. Uterine size vivo and expressed accurately instead of by going the conventional uterine size in weeks of gestation. So what is the volume and what is the weight of the uterus is almost similar. And when we deliver the uterus, and we have found out it's almost similar. And the third point is this little mathematics. Uterine volume, if there is a uterine fibroid, I think you will agree with me, Dr. Beru, and you have taught we have to find it out, the fibroid volume different, and the fibroid which is into the uterine cavity, we should know the subserous fibroid should be added to the uterine volume. So I am very simple and simply, what is the uterine volume? Length, breadth, AP diameter 0.52, multiply karke jo volume aega, that's very, very important. So now what is this? Life is adventurous, dare it. And decision making for the route and the technique of hysterectomy is very, very important. And we have the value of uterine volume. Estimated ultrasonographically, and that's very important. Now how to judge the feasibility? Are we able to do this uterus or not? There should be a bimanual pelvic examination, especially under anesthesia. It is not possible. Then still we should be able to do the correct bimanual examination. We should have a 3-dimensional idea about the size of uterus, and actually the decision making is only 1 dimension. Again, the uterine length which denotes in the weeks, and avoid dependence on the finding purely on the fundal height. That's another important point, and sonographic estimation of uterine volume is a great help. So make it a point, one and foremost, we have volume before doing any surgery. Man cannot discover new oceans unless he has the courage to lose the sight of the shore, and that's very important. Now how to reach the fundus? Because the size of the uterus is so big, volume goes assurance distance of the fundus, how much more remains after the uterine ligation completed. So while doing the hysterectomy also, we are supposed to see how much we have left, do the bimanual examination, find it out. This is another important point, and reaching of the thing. So this is the one technique which I prefer doing about the large uterus. This uterus is not big, but I am just telling you the technique which we should do. Just do by giving, because we have enough space into the posterior vaginal side. So all the coring, all the bulking, all the debulking, all the veg resection, everything should be done vaginally, posterior side, so that we are not going to injure anything after the clamping of the uterines, because see, there is no bleeding because we have already clamped the uterines. So while doing a put incision, this is a small, just for the demonstration I am talking about. So we can do the coring for big size of uterus, we can do the morcellation, we can do the veg resection, and we can just make the uterus size small by removing a small pieces. So this is the one you can say veg resection, anything like that. Again, the indication should be really good. It should be very close to heart. Simple cervicitis should not be the indication, or simple AUB of the first bout should not be the indication. Indication, there should be a right indication for anything. So this is the one of the type of morcellation. Then the next, this is one other thing we can make the uterus descent, is like simple thing by holding the vulsum at 3 o'clock and a 6 o'clock position. And we can cut it anteriorly also, and we can cut it posteriorly also. So you can see how the uterus is coming. This is a demonstration on a small size, but this is the way we do it. See, the same on the posterior side. We are very safe. See, the size of bleeding and everything is a clear cut. How uterus is coming down, you can see and you can appreciate. because I am going up to posterior side, see the uterus will deliver it out by itself. This is only, I think, 12-week size or 14-week size uterus, but the technique should be same for the bigger size of uterus. So see how the uterus is coming out. So the objectives of debulking, what should be the objective of debulking is, number one, is secure the uterine vessels first, bisect the cervix upwards, then morcellate the thick uterine volume from inside, and fourth important, if there is a big myomas, enucleate the myomas. This is another technique which we use. When we reach to the anterior side, we can again morcellate, again doing the things. And simple monopolar, I am not using anything special. All the coring can be done. So this is a video of 3 minutes, if you'll permit me. It's unedited video and it is being published into the AAGL also. They have accepted this video for this, and this is almost 18-week size of uterus and we are delivering. I'll make it fast so that you can see. The first myoma screw, first fibroid on the cervical fibroid removed, securing the uterine vessels. It's unedited one. No editing being done. And for other videos also, you can go to the Kavita Bapat YouTube channel. I have a great number of followers. Thank you so much for that. And you can see, the youngsters can learn many more things from it. So this is another way of doing things. Again, I am repeatedly saying you need a good assistance. इसका speed fast कर सकते हैं क्या? कि चलने दो. Let me, I have 2 minutes more. Dr. Virkar? हाँ, 2 more minutes, yeah. So this is the way, this is the thing. Yeah, तेजी से चले तो मैं इसको चला लूँ ऐसा. It's okay. Thank you so much. So again, securing the uterine vessels. This is another fibroid is coming. And the worst part is, which I feel about the vaginal surgeons, Dr. Gurram and everybody will appreciate, हमारा recording करना उतना अच्छा नहीं हो पाता है जितना laparoscopic surgeons का होता है. सारा glamour ही खत्म हो जाता है हमारा. All the glamour goes down कि क्या है ये लोग नीचे vagina से कुछ निकाल रहे हैं. Am I not? But I am telling you, vaginal surgery, every OB-GYNist should learn, before learning the laparoscopic surgery, one point, they should learn to, and another important as a again manifesto for me is one is, every obstetrician should work at least 10 years for the obstetrics and then they should go for any other thing. I'm sorry to say, झाले पास की एकदम infertility specialist, fetal medicine specialist, either they become, what other branch? As vaginal aesthetics. I don't know what they are doing. They are doing tremendous thing. One more branch other than laparoscopy, IVF. So I think at least they should work for this country for 10 years, sir. Am I right, sir? 10 वर्ष त्यांनी कुठे जाऊन तरी obstetrics तर definitely केलं पाहिजे. Then only they should anything. Only 3 years of PG is not for the obstetrics. This country, to reduce the maternal mortality and everything, this is another big one has come out, I think. That's another. There were several of this and that, because it was not one big uterus was like that of this, but myoma screw and the assistance and all are important. And the confidence is always there, but it should not be that. I should not dare where I am not able to do it. It's not a show off. It's the thing. And the first and most thing, whenever you do this type of surgery, take a consent. I don't have any ego. I can do abdominal. I can change my route of surgery. I am trying. If patient is ready, then it's okay. And another important point, daycare surgery I do. I discharge the patient in 24 hours. It again another not egoistic point. कि मी उद्या सुट्टी करीनच. Not necessary. I can discharge the patient 3 days after also. What is the best for my patient? What is the best for me? That's first. And then only all those things. These are the techniques which we use, and we say the blood loss is not also much because of this, because all the uterines are already clamped. So this is another thing. And everything which I am doing is outside the vagina. I am not inside that, and the things which I am not removing, which are not into it. It looks brutal sometimes. Honestly, I am saying it. And is it good or not? I don't know. But what I think, one can try. It's not that everyone should do it. If you are good, if you are able to do it, try it. Because the patient goes so well in 24 hours. Patient is so happy without cutting the abdomen and everything. So this is another piece of this. I am not doing the advocating of doing 20-week size of uterus. I am just telling you this can be done. Not like that. The person who is like that, I think, should I stop it? I think it's one more minute. There's so many. Hela fast karta hai ilka. It's not moving. It's okay. A little fast I want. I have archa, anterior fibroid, big anterior fibroid is coming. थोड़ा सा करते हैं तुला थोड़ा सा फॉरवर्ड थोड़ी फास्ट नको मराव दे येईल कसं करशील कर थोड़ा सा I don't know no even this one हाँ याला थोड़ा सा फॉरवर्ड it's just a little forward fast करून टाक finish कर I'll be happy yeah the last portion should be seen it's okay रहने दे उसको वो पढ़ाई कर रहा है वो इट्स ओके बिकॉज इट्स अ 20-week size uterus नो एटलीस्ट 1.5 मिनट तो लेगा वो स्टॉप इट बंद करून बाहेर चालू इट वोंट गो इट्स नो इश्यू सो this is another point it's a uterus got it from it but before concluding 2 slides more is left I think I like to talk about it those slides उसको नहीं करना था मैं मना कर रही थी छोड़ दो leave it इसको बंद कर दो yeah stop it so concluding point is whenever we take a decision of doing a big uterus what should be in our mind and what we are doing is another important point क्या कर रहा है दो स्लाइड बची है so it should be number 1 is the surgeon's decision. Number 2, we should find it out what is the volume of the uterus. Number 3, we should explain the correct counseling to the patient. Number 4th point is real preoperative assessment of the patient. Do we are able to do it or not doing? And all the counseling points, explain the risk about it. And isko nahi karna tha. It's okay. Speak. Chhod do usko. So thank you so much once again because I think this is not allowing me to speak. Huh? No issue. That's not a big thing. Thank you so much. Last की 3 slide दिखा दे, इसको ज़्यादा नहीं दिखाना है. Yeah, that's important also for me. Yeah. आला मोटर छोड़ दो. Yeah, take home speech. So these were the big things. It's okay. I think I am not, and this is not my patient, just for the show off. This patient photo is. So the uterine volume measured ultrasonography prior to the operation related outcome, it's very, very important. If it's less than 100, 101 or 201, what we can do? Up to 401 vaginal. But if the vaginal expert is there and the volume is more than 500, we should think about need of a laparotomy, more than 500 volume. We need to debulk more of the patients when we start from the 301 to 401. If should we have the pelvic space should be more, and when the size of uterus is more than 500, there is no space, and these are the points. So uterine volume less than 100, easy for every gynecologist. 100 to 200, gynecologist should able to do it. 201 to 400, best performed by the gynecologist who have the backup experience. 200 and more, 200 and 300 more may need debulking. 240 to 350, scheduled trial vaginal hysterectomy, tell them that we are going to do that. So the DARE is 12 to 14 size, perfect. Number 2, 200 volume we should think of. We should have the restrict motor and adnexal pathology. Again, if the cervix is flushed with a vagina, inaccessible cervix, there is a vaginal fistula brevis, or the invasive cancer is there, we should be worried about. And these are 4 important points, and we should have experienced assistance. We should have a backup experience, we should have considered trial, and we should have a self-confidence and a perseverance. And whatever the decisions, people, strategy and execution and fun we should do, We should take a detailed history, careful examination, consultation, examine her in a superflexion position. Clinically, uterine size and a sonographic uterine volume should be weighed. Reliable sonologist, very important. Examination under anesthesia is important. And experienced anesthesiologist to maintain our BP between 110 to 70 throughout the surgery, that's another important. The surgeons should do up to 12-week size of uterus, as Dr. Chitnis already said. We should be worried about the mobility, adherent pathology, diminution vaginal space, all are there. And one-day hysterectomy criteria is the operation, preoperative day care procedure is really good. Are the patient's home circumstances adequate for the surgery discharge? Is there anything that patient be admitting them overnight could do done to the home? And the smile and dare. So take home messages, be awesome, be awful, be fearless, be honest. Be honest is very important. Be kind to yourself, to your patient. Be spontaneous for everyone. Be still, be yourself, beautiful chaos. But why? And this is the minimal invasive vaginal hysterectomy I love to talk about. It's a fast, no oxygen, no carbon dioxide, latest, reliable, convenient, blood loss, world-classly acclaimed, less duration of anesthesia, not going through the 7 layers of abdomen. It's a height of cost cutting. The बेचारा 2 ही पैर पे दौड़ लेता है हमारे जैसा vaginal surgeon. So thank you so much. I'm contesting for the post of President Foxy. Support. Thank you so much. Samir, thank you so much. Thank you so much.
Thank you, madam. It was a really wonderful lecture today, and we have taken a lot of points to be taken home messages from your lecture. That madam has told not to do. If you have a daring to do beyond 14, what should we do? That is the lecture has taught us today. It was wonderful. And minimal invasive surgery, how it is useful to assess, use a cryocautery as well as minimal instruments with the role of sonography before doing another surgery. It was wonderful presentation, madam. I think the youngsters which are in this today will take a lot of inspiration from your today's lecture and go for a surgery beyond 14 weeks of pregnancy, 14 weeks of the size. Thank you very much. Thank you, Society, for giving us opportunity to chair this session. Thank you.
Thank you, Chairperson. I request our chairpersons to felicitate the speakers. Dr. Vaibhav Meru, sir. Our teacher, Chitnis Madam. Dr. Kavita Bapat, madam.
तू ले ले ना बाद में निकाल के फोटो तू ले ले मेरी कार फोटो
I request our president to felicitate the chairpersons. Thank you, chairpersons, and thank you all the speakers. Now, in short time, we are moving towards the inauguration.
After such a wonderful and informative session, we now move on to the inauguration of today's CME. I request Dr. Kavita Bapat Madam, Dr. Chitnis Madam, Dr. Vijay Pawar, Dr. Guram Sir, and Dr. Meru Sir to please come on the dais. I also request our President, Dr. Virkar Sir, Dr. Meena, and Dr. Khare to please be seated on dais. It gives me immense pleasure to welcome you all for today's inauguration of this CME. Lamp lighting is a symbol of auspiciousness, prosperity, and knowledge. I request all the dignitaries on the dais to please come forward for lamp lighting and symbolically inaugurate today's CME.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा प्रथमेश्वरा गणदेश्वरा चिन्तामणि परमेश्वरा वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा प्रथमेश्वरा गणदेश्वरा चिन्तामणि परमेश्वरा गण
Thank you. I now call upon our dynamic president, Dr. Virkar sir, to please say a few words on this occasion.
Good morning, one and all. Respected dignitaries on the dais, seniors, and dear colleagues. As you know, after cesarean section, hysterectomy is the most common surgery performed by the gynecologist. With this, now the trend is towards those approaches which are minimally invasive, less painful, have a less complications, less blood loss, and more cosmetic. So the TLH and NDVH have gained popularity. I also gladly remember those days when Chitnis madam taught us as NDVS as well as clampless vaginal hysterectomies. So NDVH is a simple but effective technique of operating for benign pathology of the uterus. For the better results of NDVH, there are the knowledgeable words from the stalwarts in this field. Exercise good clinical judgment and comfort with surgical anatomy. Willingness to re-evaluate and look beyond by gradually marching and mastering the art of vaginal surgeries. Keep learning, teaching, and mastering. Thank you.
Thank you, sir. I thank everybody for being with us for this inauguration ceremony. Thank you very much. In next few minutes, we'll start with the next session. Now begin with our next session. I request the chairperson for this session, Dr. Neeta Ghate madam and Dr. Bakul Jagirdar, to please take their seat. Dr. Neeta Ghate madam, she is a consultant at Markandeya Hospital and a PG student teacher. She was an assistant professor at VMGMC. She has done fellowship in minimal access surgery, and her areas of interest are teaching the PG students and high-risk obstetric management. Dr. Bakul Jagidar, she is a consultant at Chitale Clinic and also at Ashwini Sahakari Rugnalay. She has presented papers at various national conferences, and her area of special interest is high-risk obstetric. Over to you, ma'am.
Very good afternoon to everyone. Our today's speaker, Dr. Manik Gurram sir. Actually, there is no introduction need about Dr. Gurram sir. He was organizing secretary of SOGS in 2015. He is secretary of NOHIS India. He was president of IMA Solapur. He is best IMA president at national level. He was past president of Obstetric Gynec Society. He is very active member of Obstetric Gynec Society, and we are seeing his presentation and also the workshops on NDVH. He conducted many workshops of NDVH at Solapur and outside, and looking at his surgery is really the advertisement of thumbs up. That is डर के आगे जीत है. आपण ऋतिक रोशनला पाहतो, मध्येच गाडी बंद पडते आणि तरी तो त्याच स्पीडनी परत ती गाडी चालवतो. इट इज नॉट पॉसिबल फॉर एव्हरीबडी. त्या ॲडच्या खाली लिहिलेलं आहे, कुणी असे स्टंट करू नयेत. त्या हां, तर ज्यांना दोज हू डेअर they can go for this high risk vaginal hysterectomies more than 14 weeks, like Kavita Bapat madam, Chitnis madam, and Gurram sir. I am one of the witness of his surgery, as we are working together at Solapur Sahakari Rugnalay. Many patients he operated and treated. When we used to see, आमचा जरासा श्वास बंद पडायचा तर पुढे काय होतं म्हणून. पण ते युटरस व्यवस्थित येऊन पेशंट व्यवस्थित बरे झालेले आहेत. ओव्हर टू यू सर.
Madam, thank you. I first thank Solapur Obstetric Gynec Society to give me this lecture in front of my gurus, my teachers. मी वजानल हिस्टेक्टॉमी तुम्हाला सगळ्यांना माहिती असेल की सोलापूर VM मेडिकल कॉलेज या ठिकाणी त्यावेळेला प्रोलॅप्सच्या हिस्टेक्टॉमी सगळ्यात जास्त व्हायच्या आणि वजानल हिस्टेक्टॉमी सगळ्यात जास्त व्हायच्या आणि त्या शिकण्यासाठी आम्ही असिस्ट करायला आम्ही पहिल्यांदा तयार असायचो, कारण असिस्ट केल्यानंतरच ते काय चाललं हे आपल्याला दिसायचं. तर त्यावेळेला सरदेसाई मॅडम, मुनोत मॅडम, चिटणीस मॅडम आणि महाले सर, दीज आर द 4 टीचर्स की ज्यांच्याकडनं वजानल हिस्टेक्टॉमी कॉम्प्लिकेशन असेल तरीसुद्धा कशी करायची हे शिकले. आणि त्यानंतर आत्ता थोड्या वेळापूर्वी ज्यांनी लेक्चर दिलं, मी त्यांना म्हणेन, मी मुद्दाम मराठीत बोलतो आहे, त्यांना म्हणेन शी इज अ लेडी अमिताभ ऑफ वजानल हिस्टेक्टॉमी. रिअली. आणि मी त्यांच्यासमोर बोलायचं म्हणून बोलत नाही, मी मनापासून बोलतो आहे. बिकॉज आय डिड अ वर्कशॉप ॲट हर हॉस्पिटल ॲट इंदोर अँड आय सॉ हाऊ शी डज. सो वी विल स्टार्ट. ॲज अ नो, nowadays the number of cesarean sections are increasing, and in the future, after 10 years, 15 years, definitely you will get patients of hysterectomy with scarred uterus, and that is the most important thing. There are chances of complication. First of all, I would like one answer. A non-scarred uterus, no descent, 10 weeks with DUB, failed medical management, now patient want hysterectomy, how many will go for laparoscopic hysterectomy, how many will go for abdominal hysterectomy, and how many will go for NDVH. आणि ती पेशंट आपल्या घरची असेल, बापट मॅडमने विचारलं तेच विचारतो, ती पेशंट आपल्या घरची असेल तर मला माहिती आहे सगळेजण म्हणतील की नॉर्मल साईज युट्रस 10 वीक्स आहे, वजनली जायलाच पाहिजे. येस, जायलाच पाहिजे. देन there are various ways to perform the hysterectomy. Vaginal hysterectomy with use of clamps and ligation of pedicles. We see Dr. Ashish Kubde, Dr. Girish Kumtekar, Dr. Mukesh Rathi ह्या पद्धतीने करतात. Then clampless vaginal hysterectomy. That means no clamp is used, only a finger that will go inside and catch hold the pedicle and ligate. सर चिटणीस मॅडम त्या पद्धतीने करतात किंवा परीक मॅडम ज्या पद्धतीने करतात ती ही पद्धत. अँड नाव इन फ्युचर दिस विल बी, आत्ता सध्या जी आपण वापरतोच आहे वजानल हिस्टेक्टॉमी विथ एनर्जी सोर्सेस. फॅक्टर्स लिमिटिंग वजानल रूट ऑफ हिस्टेक्टॉमी. आपण सगळे काही वजानली करू शकतो का? नाही. काही फॅक्टर्स जे असे आहेत की लॅक ऑफ डिसेंट, प्रेझन्स ऑफ फायब्रॉइड्स, नीड ऑफ प्रोफिलॅक्टिक ओपेरेक्टॉमी अँड स्कार्ड युट्रस, हे ज्या वेळेला असतात त्यावेळेला आपल्या मनामध्ये किंतु निर्माण होतो की वेदर आय विल डू दिस हिस्टेक्टॉमी ऑर नॉट. बट द मोस्ट इम्पॉर्टंट थिंग इज an important point noted in the study of gynecologists who currently perform lap hysterectomy have highest successful vaginal hysterectomy rates and predict the greatest role in the future. That means सगळे लॅप्रोस्कोपिक सर्जरी करणारे जर का वजानल हिस्टेक्टॉमीकडे उतरले तर वजानल हिस्टेक्टॉमी चांगल्या पद्धतीने होऊ शकते. ओनली थिंग इज इट शुड बी इन देअर माइंड. सो प्रेडिक्शन ऑफ NDVH, as I said, nowadays the scar is increasing, fibroids are increasing. So whether we can predict whether this NDVH is possible or not? Yes, there are some parameters. One is mobility of the uterus, narrow vagina, uterine size, endometriosis, removal of adnexa required or not, then post cesarean section or myomectomy काही scar झालेला आहे का, puckering of POD, and for all these the minimum score is 7. All these, if it is mobile 1, if it is restricted 6, so 1 to 6 असंच त्याला स्कोरिंग दिलेलं आहे. आणि हे स्कोरिंग ज्या वेळेला आपण एकत्र करतो, if the minimum score is 7, it means the chances of conversion is nil. You can 100% deliver this uterus vaginally. If the scoring is 7 to 11, it is a safe score. with some skill, you can remove the uterus vaginally. But when the score is more than 16, in this case, the chances of conversion to abdominal or laparoscopy are more. So, we have to do according to this score. It is the same. Yes, as Chitnis madam told, 10 steps vaginal hysterectomy. From various surgeons, त्यांनी प्रत्येकाने स्वतःचे वेगवेगळे स्टेप्स केले आणि मग मायकल स्टार्कने हे 10 स्टेप्समध्ये जे स्टेप्स कंपल्सरी करावेच लागतील, these steps must be done during the vaginal hysterectomy. The incision on the vaginal wall, detaching the bladder, opening the posterior peritoneum, dissection of the lower part of the uterosacrals, then cutting and lightening the uterine arteries, opening the anterior peritoneum, dissection of upper part of the uterus, then leaving the peritoneum open, so peritoneum close करायची गरज नाही आहे. Then reconstruction of the pelvic floor if required. Suppose that patient is having a cystocele, then anterior colporrhaphy, posterior colporrhaphy, and if required, sacrospinous fixation, and lastly, closing of the vaginal wall. So this is the 10-step vaginal hysterectomy. NDVH, is that easy or difficult? It is easy. No. But with practice, we can do it. Initiate simple hysterectomy, then you can approach the difficult case. Learn, practice, and achieve. I am giving few tips and tricks of NDVH in a normal size uterus and in a difficult cases. So the tips is, any gynecologist who can insert a speculum, catches a cervix, and do suction evacuation, I will say he can do NDVH of a normal size uterus. And with practice, a step ladder technique, a bipolar energy sources, later on definitely can deal with the difficult cases. Yes, the most important thing, what are the various instruments you need? For difficult cases, you need these instruments. This is a paw, this is a myomectomy screw. Then these are the energy sources. Then if you want to remove the adnexa, then this is a series shades clamp. So these are the things you should be in your hand. But one thing, for a laparoscopic surgery, you need 2 boxes, big boxes, light source, camera, TV. But here, only this much is the instruments which I will take whenever I am going to do the vaginal hysterectomy. Yes, these are the various instruments. Instruments are not very special and not costly. Yes, another thing which is required is a good vision and always try to record. Laparoscopic surgery आपल्याला बघायला फार चांगली वाटते कारण कॅमेरावरून डायरेक्टली ती रेकॉर्डिंग जे होतं मध्ये कोणाचं डोकं येत नाही रेकॉर्डिंग करताना. फॉर दॅट थिंग दिस इज व्हेरी इम्पॉर्टंट. आपण जर का डोक्यावर एक बँड टाकला आणि त्याला जर का कॅमेरा अटॅच केला, आपला साधा मोबाईल कॅमेरा अटॅच केला डोक्यावर बँड टाकून, तर जे काही तुम्ही बघताय ऑपरेट करताना ते सगळंच्या सगळं तसंच्या तसं कोणाचंही मध्ये न येता रेकॉर्ड करता येतं. अँड विथ दिस यू मस्ट रेकॉर्ड एव्हरी सर्जरी अँड यू मस्ट सी ॲट द एंड ऑफ द सर्जरी की कुठं कुठं आपण आपल्याला वेळ लागला, कुठं आपण लवकर करू शकतो, कुठं चूक झाली. सर, द रेकॉर्डिंग इज व्हेरी इम्पॉर्टंट. द मोस्ट इम्पॉर्टंट थिंग इज इफ यू वॉन्ट टू लर्न. अच्छा, अरे एक मिनिट इकडे. नाही, ठीक आहे ठीक आहे, करतो मी करतो. Yes. The most important thing in difficult cases, Surendra, Samindra, hang झाले रे. एक मिनिट, मला हे करायचं. तो हा सर नाही, मला व्हिडिओ आहे तो ओपन होईना.
डुप्लिकेट करू का?
नाही, काम कर, थांब. तो प्रेझेंटर काढून टाक, काढून टाक, प्रेझेंटर काढून टाक, पूर्ण बंद कर, नवीन कर. येस, PC स्क्रीन ओनली, डुप्लिकेट. येस, yes. To learn about the electrosurgery, this is the main important thing. Take one cautery, take one bipolar forceps or bipolar scissor, use the placenta, which is the best material as physiological as the uterus. And on a wet placenta, try using this electrocautery and try to cauterize that vessels, single vessels, and cut it. With this, you can do exactly practice what you should do on the patient. Okay. Then this is position of the patient on the table. I will not go into detail about this. Then examination of the table is most important. In a previous section case, examination on the table is most important. And the thing is, here, if there is a ventrosuspended uterus, examination on the table and sounding of the uterus, and just move that sound so that the abdomen, whether it is going inside, that will confirm the ventrosuspension of the uterus. Another thing, as Dr. Meru sir has previously said, the ultrasonography with full bladder and ultrasonography without bladder, full bladder. This will definitely give you whether the uterus is ventrosuspended or not. In a previous abdominal surgery, anterior adhesions, whether uterus attached to the anterior abdominal wall is confirmed by uterine sound. Then other thing you should look is the posterior Douglas pouch. Look for any dimples and puckering. Select case properly for LAVH. So if there is a puckering, in the Douglas pouch, in that case, use aqua dissection so that you cut that Douglas pouch in a layer by layer in between the artery forceps. And still, if it is not possible, then catch hold of the cervix posteriorly and start cutting the posterior lip of the cervix, then you will definitely enter into the Douglas pouch. This is another approach. At this Douglas pouch, whenever there are adhesions, the most important thing is, whenever there is a yellow tissue coming in front of you, the fat belong to rectum is the dictum. So go away from that yellow tissue. And if you keep this in your mind, definitely you will not open the rectum. Then this is about the labial suturing. Always, whenever you are doing the labial suturing, it should be not in a parallel, perpendicularly. Suppose if you are taking the incision at the labia on at this place, then on the vagina it should be slightly lower. Because when you put the speculum, you will drag that vagina down. So it should not be like this, it should be in a slightly. Then in any undescended uterus, if you give a uterosacral massage, definitely the uterus comes down about 1 centimeter. Because uterosacral is a muscle. Whenever you give a massage, and I have seen many times, the left uterosacral immediately comes down. Right, it is difficult. I don't know how it is seen, but whenever you give massage with your left finger on the right uterosacral, it comes down. Then for aqua dissection, use normal saline or adrenaline or vasopressin. Don't use 2% xylocaine for aqua dissection. And always use 18 number needle with 10 cc syringe, not 28 number or 26 number. Then comes in a previous cesarean section, how will you open the anterior pouch? Whenever you are doing a cesarean section, आपण जे इन्सिजन घेतो ते दोन्ही युट्राईनच्या मध्ये घेतो, राईट. युट्राईनच्या पलीकडे कधी जात नाही, म्हणजे युट्राईन वेसल आपल्याला कधी इन्साइजच करायची नसते. त्याचा अर्थ असा होतो की दोन युट्राईनच्या बाजूला जे टिश्यू असतो त्या ठिकाणी आपण कधीच जात नाही, त्यामुळे तिथं कधी ॲडिजन्स होणार नाहीत, That is a surgical window, or Dr. Shiri space म्हणतो आपण त्याला. So inside the anterovaginal wall at cervicovaginal junction above the cervix with a blade, no difficulty in a non-scarred uterus. But in a scarred uterus, you should go laterally to the surgical window, to the uterine vessel, or you should do it by posterior approach. So whenever there is a scarred uterus or a previous C-section section, don't rush for the bladder dissection. If difficulty, open the Douglas pouch, dissect laterally, take the uterosacrals. You can do extraperitoneal uterine vessel ligation and then come through the laterally to the surgical window with a right angle mixture. You can come laterally and exactly open the uterovesical space, and in between that right angle mixture, you can incise the uterovesical space. So this will definitely prevent the bladder injury. Then opening the Douglas pouch, I already told you about this. But where there is a difficulty in opening the Douglas pouch, if there is a endometriosis, then there is a puckering and definitely there is a obliteration, then there is an injury to the rectum. So here go slowly with aqua dissection, you can open the Douglas pouch. Then uterosacral on the both sides to be released from the uterus by finger, clamp or bipolar. I prefer bipolar. At lateral aspect, keep vagina along with the uterosacral. With number of vicryl, this is one important tip. After taking the uterosacral, I am taking with the cautery. But still I am saying here, take a number one vicryl suture, transfix that uterosacral stump. This is not for the hemostasis. After transfixing that uterosacral stump, pass it to the posterior peritoneum through the vagina on both sides. So what will happen, this uterosacral will stay there, and at the end of the surgery, when you want to do posterior peritoneum attachment, and at that time, you will be having already two threads of the vicryl, which are having uterosacral. So definitely, these uterosacrals are automatically get attached to the posterior wall of the uterus. So there will be suspension of the vaginal vault. Then comes the uterine pedicles. Uterine pedicles, always, it should be skeletonized, and then in between the mixture, I always use thermal energy, that is the bipolar energy. With bipolar energy, the thing is, there are many ways of doing with the clamps. Nowadays, I am using a bipolar shearer. This shearer, it cauterizes and at the end it cuts. So in previous scarred uterus, just imagine LSCS, which I already wrote, but always remain toward the uterus and make uterines visible, then and then only deal with them. Yes, you can see, these are the uterine pedicles by different methods. You can see here, this is the, with a barber, then this is on the mixture, you can actually lift the vessel and you can coagulate. Then comes the adnexal release. At the adnexa, when you reach the adnexa, this is the most difficult point, because the chances of adnexa going inside without hemostasis are more. So here, take a Ellis forceps, catch hold the round ligament, and then start whatever surgery you want. Suppose it slips, this Ellis forceps which you are holding the round ligament, by this you can completely, that adnexa you can bring it down and you can do hemostasis. Yes. Then the simple question many will ask, suppose there is an ovarian cyst or there is I want to remove the ovary, then with NDVH it is not possible. No, it's possible. As you can see here, this is the round ligament that is holding the round ligament, and this is the ovarian cyst. You can see here, just puncture this ovarian cyst with a needle, then that complete ovarian cyst will be in front of you. Then with bipolar energy source, you can remove that ovary completely. Here I am showing NDVH with a shearer in a previous 2 season section, a full video where you can exactly know how this laterally we can approach. Yes, this is the complete video. I will the circumference incision. Instead of scalpel, you can use, this is a shearer. This is a bipolar shearer. The shearer which you use for the laparoscopic surgery is a long shearer, but it is a short shearer. Then Douglas pouch opening. Then cervico-vaginal area is dissected. Then with a mixture which is going posteriorly, and actually as we are hooking it on the finger, I am hooking it on the mixture, and I open the mixture, and in between the two pronges of the mixture, use the energy source. There will be no bleeding, and the uterosacrus will be completely detached from the uterus. Yes, with mixture, this is the vagino-cervical space which is opening. Even though it is the previous cesarean section cell, when we are going laterally, definitely you will get the space. Then this is the uterines. At 3 places, always cauterize at 3 places and cut medially. In between the mixture, there is a uterine vessel. It is a big vessel, but still you can see at 3 places cauterize, and then at the end it will cut. We are using here is a bipolar cutting current. This bipolar cutting current, when you use the instrument in a slightly not with pressure, it will coagulate. And when you press that instrument, it will cut. So with a single instrument, you can coagulate and cut. Then after this uterine, on other side, yes, now the most important thing in a previous season section, how to approach the lateral approach for the bladder resection. As the uterines is completed, so medial to the uterines you should pass a mixture. This is a lateral approach. Yes, you can very well appreciate that space is entered, then that mixture is opened, and with bipolar energy cutting source, we are pushing that adhesions towards the fundus. But still, even though you have pushed the bladder up, don't go for directly there. Here comes the posterior approach. So instead of going anteriorly, go posteriorly, remove the posterior part of the uterus by debulking of the uterus with various things, with either myomectomy or V dissection or enucleation of some part of the subserosal coring of the uterus. Yes, this is a subserosal coring. And you can see the fundus there. And then when this fundus is seen, push your finger above the fundus, and in between your 2 fingers, you palpate whether their bladder is there or not, and then you can actually open the anteriorly peritoneum. Till now, that uterovesical fold was not completely opened. Yes, the finger is going. Here comes the finger. You can very well appreciate the finger. There is nothing in between. You can actually palpate. You can pass a mixture from behind, and you can open the peritoneum there. Then rest is easy, as you can bisect the uterus, and then you can remove them. This is regarding in difficult cases. Then comes if there is a big fibroid, volume reduction. I will not go into detail, but the only 3-4 things: coring, inverted V incision, myomectomy, and incision at various places. But the only thing is, before doing anything volume reduction, it should be done only after the uterine ligation and after opening one of the peritoneum, either anteriorly or posteriorly. Better always posteriorly. Always keep track on the seizure. As Dr. Bapat madam shown, the use of monopolar. She is confident, and after so many days, definitely monopolar is a very good instrument where it can cut that part easily. But if you are afraid of that, use scissor, because if you are using a knife, if you are using a knife, you can't have a good hold on that. But with a scissor, and if you are keeping track of this scissor, you will know up to what part you are cutting. So that is very important. Then subserosal coring, it is seen, inverted V incision, then myomectomy of the fibroid, and sometimes these cases can be seen. This is a fibroid in the uterus. It is so hard, it is not coming out. So you can see here, this is a chiseler which is used for the bone surgery in a neurosurgery. With that, and this is the paw. That fibroid is actually, it is like a stone. So these types of innovations needed sometimes. And the last is the vault closure. Don't underestimate the vault closure. Vicryl attached to the uterosacral and passes to the posterior vaginal vault, which we have already taken care. And this helps in easy approaching the vaginal vault with a good vault, suppose. And if you feel that there is a laxity, then you can go for the sacrospinous fixation. Then sometimes some complications can seen at that time of the surgery. And the most important thing is, at the end of the surgery, you should track from below upwards, from uterosacrals, uterines to the ovarian vessels, and you actually you should see whether hemostasis is there at all three places, on these sides and that side. And once it is confirmed, then and then only one should close the vaginal wall. But suppose if there is a bleeding, then how that can be tackled? Yes. How should you go for the hemostasis? First, catch hold of the uterosacral area. Then slowly with suction, continuous suction, a good vision, if you just pull that uterosacral, you can go above. You can see here there is a bleeding from one side. It is from the uterine, the ovarian vessel. Yes, you can see it. With a bipolar energy, just go there, catch hold it with bipolar, and then come out. And whenever this type of complication is there, use a normal saline with syringe and pour the normal saline there, so that the blood volume is there, which is decreased, so that your cautery which you are using, that blood will not stick to that, and you will get a good result. But at the same time, at the end of the surgery, when you push this normal saline there, then you can see a clean water is coming from there. It should not be a blood stain. So this is regarding the vessel. The take-home message is, a major challenge to the vaginal hysterectomy is inadequate training. Yes. In a recent survey of fellowship program directors, only 20% graduating obstetric and gynecology residents starting fellowship in female pelvic medicine and reconstructive surgery were deemed competent to independently perform vaginal hysterectomy. The reason behind this is, we are having a very good laparoscopic videos, but we are not having a very good vaginal videos. So whenever you are doing a surgery, record it, and if it is a difficult case, you can put it on YouTube or on various WhatsApp group. And always, these are the things we should be with you. A bipolar energy source, a good light source, a camera, a suction cannula with a light, a fiber optic light. This is very important. This can be used for any vaginal surgery, a deep surgery, this can be used. And then try various methods. Out of all these methods, I will say, with bipolar energy, the vaginal hysterectomy in a difficult case, with bipolar energy and 10-step vaginal hysterectomy, it will be easy. Thank you. Thank you very much. But the only one thing with the energy source, आपण घरी दूध आणतो, दुधाची बासुंदी करतो, मंद आचेवर तापवतो आणि मग ते एकदम मस्तपैकी बासुंदी तयार होते. सो इट शुड बी लाईक धिस ओनली. असं जर का झालं तर मग ते हे पुन्हा एकतर काढावं लागेल किंवा हे फेकून द्यावं लागेल. एनर्जी सोर्समध्ये सुद्धा इट शुड बी विथ अ लोएस्ट करंट, लोएस्ट वॅट, विथ अ बायपोलार, अँड अ स्मॉल यू कॅन गिव्ह अ स्मॉल करंट टू दॅट, सो दॅट आपण ते बासुंदीसारखं त्याचं प्रोटीनमध्ये कन्वर्ट करायला पाहिजे, ते असं चारिंग होऊ नये. थँक्यू व्हेरी मच.
Thank you, sir. Very excellent talk on NDVH. To sum up his talk, hysterectomy of the scarred uterus is scare for every obstetrician and gynecologist. Nobody want to touch scar uterus. Convert laparoscopic hysterectomy to vaginal hysterectomy. It's a good one. Scoring of feasibility of hysterectomy of NDVH. He elaborated 10-step hysterectomies and very small and very valuable messages during each step of hysterectomy. And very good steps how to achieve the hemostasis. Now it is time to start with the fellowship courses of vaginal hysterectomy at some institute, so that the newcomers, new PG students know much better about hysterectomy and chance to learn of hysterectomy. Thank you so much, sir. Now our next speaker, or any questions from audience? Okay. Now we move over to next speaker. Bakul will introduce.
Very good afternoon, everyone. We have Dr. Vijay Pawar today, who is a consultant, SIMS Fertility Center, associate professor at VM Government Medical College. He has got fellowship in ART in minimal access surgery. In his introduction, I think the most important thing is he is a very good, dedicated PG teacher, and he always encourages his students to learn new things, implement new things, and he brings new things to his setup. And that is something which I think is really commendable. He is a thorough fitness enthusiast, as we can see a transformation in him. And that just means shows his dedication, sincerity, and focused efforts towards something which he wants to achieve. It will be very interesting to learn from him today. The topic is laparoscopy versus vaginal in a way. And somebody who is very excellent vaginal surgeon will be little bit biased on this side. Somebody like Sandesh will be biased on scopy side. I think he is a balanced, Pawar sir is a balanced person because he does both the things very nicely. So it will be very interesting to know from him which are the limitations, which are the advantages of each of the trade. Thank you, sir.
Yeah, thank you. At the outset, I would like to thank the society for inviting me for giving this talk. I am actually a replacement speaker today. Again, I think this year the second time I have to substitute Dr. Impact player something. So I don't know whether I'll try to impact in some way or the other. The slides. Actually, sir, Dr. Dabre sir was supposed to present, but some unavoidable circumstances he was not there. So I am today with you for the next 10-15 minutes. I will not, I think most of the things all the previous speakers have already spoken about vaginal hysterectomy and how to do and how to deal with that. So the job for me is very simple. So we all know that now Dr. Bapat has already informed about the minimal access surgery. So the scarless surgery is a vaginal hysterectomy, and as a teacher in VM Medical College, we all know that VM Medical College is renowned for doing vaginal hysterectomies. So it is very important for all of us. Most of us are already a good vaginal surgeons. So when we evolve in surgeries, laparoscopic surgeons have to be a good vaginal surgeon before they jump into laparoscopy, because any complication happens in laparoscopy, if you're good vaginal surgeon, most of the things you can manage it minimal invasively. Otherwise, then you have to do a abdominal hysterectomy or abdominal procedure. So, vaginal route we all know is the safest and the most cost-effective route. We have already know about that. Less complications, fast recovery, shorter hospital stay. What I would like to put here about short hospital stay. With the evaluation of the ERAS protocol, that is early recovery after any surgery. So this has been especially the concept has been brought from the gastrointestinal surgeons. So now with the ERAS protocol, we have started applying this in daycare surgeries. Even in our VM Medical College, we see that the patient is within 6 hours, the patient is moving, and by actually we can discharge within 24 hours, but our patients that are staying far off, so we cannot discharge. But within 6 hours, patient actually can be discharged after a vaginal hysterectomy also, if we follow the ERAS protocol properly. So the ERAS protocol has to be followed, and if that we follow, this complications and recovery is very, very fast, and we get amazing results. Very less analgesic requirement is there for ERAS protocol. So we all know about the evaluation of the patient. So very important in pre-operative evaluation of the patient, very, very important that you examine the patient in your clinic, see that do a proper speculum examination. Guram sir has already mentioned the telltale signs of puckering of the pouch of Douglas, the nodularity of the uterosacral ligaments, or especially if there is you are suspecting any pelvic inflammatory disease, adnexal masses. Now the newer thing that has come is the deep infiltrating endometriosis. Now these are the indications where you have to go for a laparoscopic surgery, not for a vaginal surgery. So if you have a adnexal mass which is adherent to the lateral pelvic wall, then or you are suspecting any malignancy. So all this very important that whenever you are venturing for a vaginal hysterectomy, all these things have to be evaluated before. So my approach to hysterectomy is a open approach where you should know all the different skills: vaginal, abdominal, laparoscopic assisted vaginal hysterectomy. So the first approach that prioritized will be vaginal hysterectomy. Then it will come to a laparoscopic assisted vaginal hysterectomy. Or abdominal hysterectomy nowadays is only for a very, very large uterus, like Chitnis madam has already explained about the time of the surgery. So any surgery which is going more than 1.5 hours for a hysterectomy, then you have chosen the wrong route. So you have to always evaluate if your surgical time for vaginal or be it a laparoscopy, if it is increasing for more than 1.5 hours, then you should be very prudent and smart enough to immediately shift to the other routes, and always call for help whenever it is required. Keep your ego aside, call immediately for help, and change the route of the surgery immediately. We have a lot of good abdominal laparoscopic surgeons. We have now for the panel discussion, we have going to have good gastric surgeons also, and if bladder injury is there, Sharma sir is there. So all of them are available in Solapur. So Solapur in that way is a very blessed city for obstetrician and gynecologist, and most of them, all of them are very easily accessible and helpful to us. So vaginal route, natural entrance, direct approach to the cervix and uterus, all the indications are increasing. So trial of vaginal hysterectomy is very, very important. Intraoperatively, when you give anesthesia, evaluate the patient again under anesthesia, because after giving the spinal, the non-descent becomes first degree descent. If you give massage to the uterosacral ligaments, give traction, it will become second degree descent, and it will, the NDVH becomes like a second degree or a first degree prolapse type of surgery. So very, very important that your anesthetist has given proper anesthesia, and your evaluation is very important before proceeding with the surgery. If you want to do any adnexal surgery along with your vaginal surgery, and if it is difficult to do vaginal, Guram sir has already mentioned about how to remove the ovarian cyst, but always remember that you already also have a laparoscope with you. So you can do the vaginal from below, and the laparoscopic part for the adnexal surgery can be tackled by laparoscopy later on, or vice versa. So always have all alternative routes available in the OT. Don't just prepare the trolley only for vaginal hysterectomy. Keep your trolley for abdominal hysterectomy as well as laparoscopic hysterectomy ready with you for all cases, and always give the vaginal trial for the hysterectomy. So we all have known about the advantages of this surgery. No costly instrument. It can be done under regional anesthesia, short hospital stay, and the learning curve is very short if you know the surgery properly. Now, Guram sir mentioned about the 20% students are getting vaginal in expertise. I think those studies must be from abroad. In Solapur, I don't think our institute any resident goes without proper training of vaginal hysterectomy. Maybe laparoscopy I can agree, but vaginal surgery, all of them become perfect at least by finishing their SR post. So short learning curve, 3-4 years of training with in residency at proper institute can give a good surgery. And most important thing for vaginal hysterectomy is that it can be done in the periphery with very short amount of, you don't require fancy instruments and costly instruments. The cost of the surgery for our patient can also be reduced. The only problem once I faced for vaginal hysterectomy, because I was trained in Sion Hospital. So in 2010 when I started my practice here, I started doing NDVH for all patients. And one day I did a hysterectomy for one lady, पिठाची गिरणी चालवायची ती. So she came for some pathology. She had a fibroid around 12-14 week size uterus, and I was very enthusiastic. So I finished her surgery, and she went home on the second day. Fourth day, her relatives came to me for fighting that you have not done the hysterectomy, and तुम्ही पेशंटला असंच घरी पाठवून दिलेलं आहे. असं शक्यच होत नाही की पेशंट 2 दिवसात, बिकॉज शी स्टार्टेड वर्किंग अगेन इन द गिरणी. सो her son was very suspicious that I have not done the hysterectomy. I just gave her anesthesia and sent her back. So I had to do her ultrasound again and show him, convinced him that I have actually done the surgery. So this is what happens with the recovery. That is how the fast recovery that happens with vaginal hysterectomy. And the other thing, again, Bapat madam had already mentioned about the vault closure. Now we are always trained to suture the vault horizontally. The newer trend is to suture it vertically. The reason being is that the length of the vagina increases. That is one thing, and also you have to do the vault suspension with the uterosacral ligament, like Guram sir mentioned that you have to take nowadays with bipolar when you are doing. So you should actually support the uterosacral to the vault. The reason is the shortening of the vaginal length. Most of the patients have sexual dysfunction because of that. So many women don't want vaginal hysterectomy just for the shortening of the vagina. So that part also can be tackled by this suturing of the vault vertically. So that is one thing that we all should remember. And obviously for laparoscopy, it is not a scarless hysterectomy now coming with single port hysterectomy, and it actually increases the difficult. Nowadays we are Sandesh has tried hysterectomy with a 3 mm port also. So we have 3 mm ports and a 5 mm scope through the umbilicus. So that is the level of minimalism that has gone into laparoscopy. But again, there you have to very big learning curve. The amount of time that you take for the surgery increases compared to vaginal. Guram sir and all of our surgeons here do it within 15-20 minutes. They finish the vaginal hysterectomy. Difficult or this minimal, single port laparoscopy, inadvertently it takes more than 1.5 hours. So this is the problem. Most of the times it is more of a fancy things, marketing thing that laparoscopy is better than vaginal. But I think vaginal hysterectomy has its own place. We all know about the complications of TLH, nothing to go into that. There will be specific indications for TLH. Previously 2-3 LSCS, lot of adhesions are there, grade 3 and grade 4 endometriosis is there, or there are some adnexal masses. Obviously for malignancies and all that, it's never going to be right now, laparoscopy is not recommended, so it will be an open surgery where abdominal hysterectomy will be done. Cervicofundal sign already sir has mentioned, I will not go into detail. Uterine size also madam has mentioned. Oophorectomy also has been mentioned. So this is the last slide. So the important point that we should know is that Vaginal hysterectomy is a trial hysterectomy that you have to consider in all cases of your hysterectomy. If there is no contraindication to vaginal hysterectomy, go for a laparoscopic evaluation. So the second step is laparoscopic assisted hysterectomy, not abdominal hysterectomy. Abdominal hysterectomy has a very limited indication nowadays, especially for malignancies or very, very difficult cases or very big size uterus. So 28 week size uterus, 32 week size uterus, don't try going for laparoscopy. Just do it, abdominal hysterectomy will finish within 20 minutes, not a big problem. But laparoscopic assisted vaginal hysterectomy, especially if you have some adnexal masses which can be tackled laparoscopically, or sometimes you want to release some adhesions, you can release it and then you can revert back to vaginal hysterectomy. So LAVH is the again part. TLH obviously will be one of the choices if you want. And if there is contraindication to vaginal hysterectomy, then again it will be LAVH. So this is the flow chart that you should remember. Abdominal hysterectomy will always be the last choice nowadays. So that is what I want to mention in this. I thank you for your patient hearing. Thank you so much for inviting me.
Thank you, Dr. Pawar, sir. Very excellent talk on laparoscopic hysterectomy. Actually, at the end of the session, I want to say that is abdominal hysterectomy is a driving two-wheeler that you see all around and you have to drive. Driving skills are important. And DVH is driving four-wheeler because the space is small, still you have to go. And laparoscopic hysterectomy is like a driving or pilot of aeroplane. It is costly as well as skills to develop take too much time. So we end up here and the next session.
Thank you, ma'am.
Over to Ketki.
Thank you, ma'am. I now request the chairperson to please felicitate our speakers. Dr. Gurram, sir. Chairpersons, please. Dr. Vijay Pawar, sir. I request Dr. Virkar, sir, to felicitate our chairpersons. Thank you, sir. We now move on to our last but the most interesting part of today's CME, the panel discussion. Every surgery might have its own sets of complications, but with utmost care, proper patient selection, precision, and expertise can prevent these complications. So the topic for today's panel discussion is complications of NDVH. I now invite our panelist, the dynamic and charming Dr. Kavita madam, always enthusiastic and a legend, Dr. Chitnis madam, a true teacher, Dr. Vijay Pawar sir, an eminent sonologist, Dr. Meru sir, a renowned surgeon and a true rescue for all of us gynecologists in times of complication, Dr. Wakde sir, and last but not the least, the person of utmost expertise and experience in the field of urology, Dr. Sharma sir. The moderator for today's panel discussion is none other than our Gurram sir. Dr. Sharma sir is a urologist at Chitare Clinic. He has more than 30 articles published in various national and international journals. He is a board member of Indian School of Urology. Hybrid technique described by him is cited in Smith's textbook of endourology. He has written a chapter on a very interesting topic, is research feasible in private practice? Our panelist, Dr. Vakde sir, he's a consultant gastroenterologist and a hepatobiliary surgeon at Ashwini Hospital. Over to you, Guram sir.
Actually, we have learned many things about the NDVH, but still, whenever there are complications, that is, it might be one for us, but for that patient, it is 100%. Every surgeon selects the surgery that provides the best results. In spite of that, something goes wrong somewhere and complication in front of us. Better to select the option that has the least complication and anticipate them. So complication rates markedly vary as for the individuals. In vaginal hysterectomy, it is associated with low incidence of complication and morbidity compared to abdominal hysterectomy. Am I right, sir? Pawar sir?
Yes, sir.
Complication rates for vaginal hysterectomy are far less than abdominal and laparoscopic hysterectomy. But like any other surgical procedure, it has its own share of problems, some of which are unique to this route of surgery. For vaginal hysterectomy also, some complications are unique. And as nowadays the number of C-sections are increasing, most bladder injuries will be seen in the vaginal hysterectomy, right? So what are the various complications related to vaginal hysterectomy? What are the various complications? That is related to only vaginal hysterectomy.
I think the most important is the bladder injury that we are scared of as a gynecologist, but it is the easiest organ to repair and forgive us. Ureteric injury is very rare in vaginal hysterectomy compared to abdominal hysterectomy. Fistulas, especially VVF or RVF, if you have gone into the wrong plane. So those are there, which are unique. Otherwise, hemorrhage, infection are very
post-operative urinary retention.
Vault hematoma or infection. Because
so these are the various things. Out of this, I think, Bapat madam, you want to say something?
To make the list, first and foremost complication is not able to do the surgery.
Yeah.
That's the biggest complication.
Conversion.
You call it complication or you don't call it a complication.
Yeah. Conversion.
It is there. And then the point comes of your ego and everything that abandon the procedure, stop the procedure and go. And that's, which is not into the list is the prolapse of your fallopian tubes into the vaginal.
It is in the next.
One, yeah, I'm sorry.
Yeah.
And anything else, madam, which is not in the list?
Difficulty in opening pouches is the utmost difficulty. Either you go deep or you go superficial. You are above, you damage the bladder, you go deep, you keep on dissecting, and then there is lot of bleeding, and then you have to leave and go to the other pouch. So pouches are very difficult. That's the first difficulty. All other difficulties they told. Another one is slipping of the ligature. On table, the anesthetist is there, they are pushing the fluids and all. So sometimes the blood pressure remains maintained. You shift the patient to the ward and suddenly she collapses. So there's a ligature slipping. Now to you cauterized, so I can't comment on that. But
yes,
we used to put ligature, so the ligature slipping is
no, we will go to that in detail. But here I am just enumerating the complication. Yeah. But before that, I want to ask Sharma sir. Sharma sir, many times you are rescued to any gynecologist. How many times you have seen ureteric injury during vaginal surgery? And
I have seen two cases. First was in the earliest part of my career where I had just finished my MCH and came to Solapur. That was at GHS. While doing vaginal hysterectomy, I was called to repair the bladder and I could see two ureteric orifices over there. So you can't call it exactly a ureteric injury, but it was very close to it. And I had seen another one where the left ureter was supposedly damaged, but it could be managed by stenting. And it is usually the left ureter which gets damaged because it is closer to the fornices as compared to the right one.
okay. So here I want some guidance from you to prevent the ureteric injury. What precaution we gynecologists should take?
See, first of all, this question becomes more pertinent with abdominal hysterectomies rather than the vaginal hysterectomies. But again, do a good abdominal sonography. That is the first and foremost. Because if you are finding signs like there is hydroureteronephrosis, especially say on the left side, then you are aware that there is some pathological changes that has occurred which has altered the anatomy, and you are likely to encounter the ureter at places where you are unlikely to get the ureter. So adhesions, pulling of the ureter is likely. And in case you are really skeptical and you feel there is a problem, in abdominal hysterectomy, I usually say you put in a DJ and you go ahead. This is very rare, and I have never been asked by any gynecologist to do it for a vaginal hysterectomy. But the third most important thing is be less aggressive and keep your ego aside. If you feel there is a difficulty, involve somebody. Ureteric injuries are very uncommon in vaginal hysterectomy, but if they are there, they would be disastrous.
Yeah.
Yes. For a gynecologist, how to prevent the ureteric injury? This is the question.
Yeah.
Huh? First and foremost, a correct mapping of the uterus, as the sonologist will do. If the fibroid's location, what is the location? We should have a diagrammatic mapping of the fibroids. So the anterior hair, posterior hair, touching the ureter's hair, crossing to ureter, number one. Number two, they should not feel, they should have a correct anatomy of these things. While clamping the uterosacrals, while clamping the Meckenrods, while clamping the they should know exactly how centimeter far your clamp will be and how it is like that. And the third important point is, while as a simple gynecologist, these injuries in cases of vessel sealing which we use, it's not basically we cut it, but we give the tissue burning or something and it appears after 3-4 days. So we should be careful to putting the clamp while this thing. And fourth important thing, it's possible, do cystoscopy in those cases and to see the ureteric, if possible, which is not the put a hysteroscope or something like that.
Madam,
it's not possible.
This I have heard at various forums, that you look at the jet of the ureter coming out. Urine coming out, there are two fallacies associated with this. It's not 100%. First fallacy and first big problem comes is this comes into play when there is a major problem that has arisen, and the patient's hemodynamic status may not allow a bolus of urine to come very easily. Secondly, a partial ureteric injury or an ischemic injury, this would manifest later, and at that particular moment you would be having a ureteric urine jet coming out. So that doesn't rule out, it just gives you a lot of satisfaction at that particular moment. Yeah.
One thing I would like to add is, when you are tying the uterines, sometimes the uterine slips. If you catch it immediately, it's right there. But if you take a little time, it retracts. When it retracts and when you try to catch it, that's the time you may injure or there may be a kinking of the ureter. So that's the time it may get damaged. And as far as possible, you have to be near the uterine side while clamping, instead of going laterally. Stay near to your organ. Don't go to these people, very bad situation occurs.
We people are not bad.
People behind the organs are dangerous.
The thing is, in a vaginal hysterectomy, ureteric injuries are less common. In a laparoscopic hysterectomy, most common. Nowadays, when you are going for high uterosacral suspension, for vault to prevent the water prolapse. In those cases, the chances of ureteric injuries are more. That is the only thing. Now we will go to one case. Hysterectomy, which route? 40-year patient, second para, first cesarean section for breech, second VBAC, lap tubectomy 10 years back. Now complaining of menorrhagia for 6 months, cystoglandular hyperplasia, patient not ready for medical line of treatment, hysterectomy, which route? Obviously. But the thing is, no, we want some answers from surgeons and urologists. That's why this question. Sir, in this case, actually, the bladder injuries are common. So, to prevent that, any specific investigation we should do, as Meru sir is already told that, but still, as a urologist, before surgery.
I would not advise any investigation prior to, to prevent a bladder injury, nothing per se.
Then,
Why should we call him preoperative?
he is a urologist.
I always come in picture
Why?
after injury, never before that.
Why you should consult him? As a gynecologist, why should I call a urologist for my case?
No, I am not calling before, but I am asking whether any pre-operative investigation you will advise. You will advise me.
I don't think for a...
Okay, no problem. Now comes the next question. Surgery is going on. How to recognize whether there is a bladder injury or not on the table? On the table.
See,
on table.
On table, usually it's the discharge of urine which somebody picks up, or the bladder mucosa protruding out, or sometimes the assistant telling you ki yes, leak ho raha hai urine.
Okay.
Yeah.
I know.
But this I would like to add. If there is a suspicion, distend the bladder with 400 ml of saline and see whether there is leak.
If there is a suspicion.
This 400 ml becomes important because very often it gets distended to 150, 200 ml, and more true with abdominal hysterectomies, and you don't get that leak of urine, and then you feel erroneously that everything is fine. So it should be an adequate distension of the bladder, and it comes to around 400 ml.
So this is important. Whenever you are suspecting some urine came out, then if you are suspecting, distend it with a catheter 400 ml of urine, definitely you will know at that time. Now, there is an injury. I have seen that there is a bladder injury. Whether I should go for hysterectomy first or I will do this bladder repair first and then go for hysterectomy.
That is your call. Makes no difference to me.
No, what are the advantages and what are the disadvantages?
See, once you have injured the bladder, you actually know where the bladder is.
Yeah.
So you know where exactly open. So if you open the bladder, just you know the planes you have gone very up. So you have to go down and identify the plane, complete your hysterectomy. Medically, you have to give a call to the surgeon. You can suture it, but nowadays I would recommend that you should call the surgeon, and you know, if surgeon is not available, obviously you can suture it. There is no problem with that.
Not even gynecologist can suture the bladder and mention it.
Yeah, Vijay,
We don't need medico-legally the surgeon over
your books mention that if it is less than 2 centimeter with no complication, the gynecologist can suture the bladder.
We don't need it. And we always tell the patient, no, that's less than 2 centimeters.
But it is always for medico-legal purpose, but it is always my advice is better to
have an
we are having the court may
I'll tell you, madam, I will tell you why the surgeon should be involved. There are 2 reasons for that. One is any complication which occurs, the operating surgeon is not in the best frame of mind. Occasional surgeon might be MS Dhoni, very cool and composed, but most of them would have tachycardia. So it's always better to involve somebody else. Second is, bladder being a forgiving organ, it's easy to suture. The crux remains is to identify whether the edges are good or they are ischemic, because this is where the chances of VVF prevention is there. And that is where somebody who handles the bladder more often than a gynecologist would be more useful, because he knows that the tissues are good or they are not so good. Hence, involving somebody is a good option.
The first one is very important.
First one is important.
medico-legal.
Because the bladder starts leaking, the gynecologist starts...
Yeah.
The moral support we always need them. And multidisciplinary approach is always
If it is available in your city, it is always best to use. Suppose I am doing at some other place where no urologist available, then no problem. Yes.
So it has to be documented.
And
that,
documentation. For all complication,
you
whatever
tried
complication you are
to call
doing,
the surgeon.
it should be documented.
Another important thing that is if you are too scared about bladder injury, you can put methylene blue before the surgery also. So especially this is what people do when they are doing learning TLH. So for TLH also there is very recommended that you put the methylene blue before the surgery and keep. Fakt see that no
Only
blue,
thing is
blue thing starts coming, that means you have injured the bladder. So you know where to go. So suspicion, doubt, all goes most of the times.
One case I would like to tell, if you permit. Overconfidence of the gynecologist is bad. I did it myself once, transverse incision, and then I thought I'll just push it up with the anterior wall retractor. Just pushed it up, and I was right inside the bladder. So overconfidence is very bad.
I have also done that once.
That means
in the beginning. The trick over there is the cervico-vaginal junction. So whenever you are taking your circumferential incision at the cervico-vaginal junction, 1 centimeter below the junction. So actually in many of that you say that you take the incision over there, but then I read in till end and they have actually mentioned that wherever you feel the sulcus, you take 1 centimeter below. And that is a very fine sentence they have written it. It is there in the book, but we miss it sometimes.
But
so
that means,
is again
very
important. If you do complication, go back to your basics, read your stuff again, you will get into it.
That means you become a true gynecologist only and only once you have opened the bladder and repaired. Yes, it is given in till end. Okay. Sir, again for the surgeons I will ask. Many of are knowing, but which material is best for the suturing of the bladder and how it should be sutured?
Ideally absorbable polygalactin 30-vicryl is ideal. If possible, suture it in 2 layers. If not, 1 layer is good enough. But keep good bladder drainage post-op.
Okay, thank you. That the next thing is post-operative precaution. What post-operative precaution?
If it's a simple clean injury, I would say 5 to 7 days is good enough. 5 days is ideal. 1 day extra for patient, 1 for gynecologist. So 7 days is what I advocate. And at the same time, give bladder relaxants so that whatever bladder spasms tend to occur because of the presence of a catheter for a longer period are prevented. But if it's a complicated injury where the edges have been quite friable, it's better to keep it for 2 to 3 weeks.
Okay.
Exactly. 7 days from the U side and 7 days from our side. So 14 days, my suggestion to you.
Very correct, ma'am.
And sir, that drug which you said.
Yeah, see, bladder relaxants, there are a lot of drugs which are available. You can give tolterodine 2 milligram or 4 milligram or solifenacin 5 milligram or 10 milligram. 5 milligram in Solapur is good enough because it causes a lot of dryness of mouth. Or you can use derifenacin, and now there are many other drugs, fesoferidine, mirabegron, a lot of them are available. But 2 are good enough, tolterodine and solifenacin, one of them can be used. 5 to 7 days is a good enough period, and that's it.
Okay, thank you. Here you can see it is in 2 layers. This is the first layer and this is the, after finishing the second layer. Okay. Now we will go to
Manik, before we go to leave the urology aside, there is one more injury which cannot be called as an injury or a complication, but which harasses the urologist far more than the gynecologist. No, it is the urethral problems that arise after any hysterectomy. Patients presenting with dysuria and lot of other symptoms related to some symptoms. And another thing which is very common to Southeast Asian countries is development of urethral stenosis following hysterectomies or any vaginal surgeries. And interestingly, if you look at the literature, the incidence of urethral stenosis in the Western world is less than 5%. But in India, it's more than 20%. And a lot of it gets related to bad catheterizations that tend to occur during pelvic surgeries.
Another point which nowadays we feel about, we have not given the right hormonal replacement therapies to these people. Because we had a surgical menopause at the end of the day. And after the surgical menopause already being developed, have we taken the care of the hormonal replacement for the, because once the surgery done, gaya patient. फिर ना हमारा है, then they कभी urethral stenosis, sometimes they have some different thing. They go to urologists, they go to several people, they go to some neurologist for all the problems. So hormonal replacement therapy post-surgically is very, very important to prevent all the urethral as well as, I agree with your stenosis problem is because of the bad catheterization, but sometimes the urethral problems are because of the lack of hormone as she grows up.
So, now we will go to the next case. A 30-year patient, primipara, laparoscopic surgery for endometriosis, now complaining of dysmenorrhea for last 12 months, ultrasonography, signs of adenomyosis, chocolate cyst 5 by 5 centimeter, on first examination puckering in DP, per vaginal uterus mobile, mass in the right adnexa, hysterectomy, of course, I will go here for NDVH. Now here I will asking Vakde sir, what are the complications which can come in this case while doing surgery?
Sir, one thing is if you have a lot of adhesions in the pelvis, while dissection you may have a rectal injury posteriorly. More often what we have seen while you proceed with dissection, the small bowel is adherent and it's very difficult to preoperatively diagnose small bowel adhesions. For endometriosis, you have very good MRIs which you can actually detect the rectal nodule and you can preoperatively predict that the rectum is involved. But believe me, working with Dr. Kadir sir, it's very, very difficult to predict small bowel adhesions. And that is the small bowel adhesions which will give you problems. Because in one case I have seen a few years back, 7-8 years back, when they were doing vaginal hysterectomy, the small bowel got pulled along with the uterine fundus. And once they were dissecting with the finger, the small bowel was ruptured. It was actually divided into 2 parts. So it is very difficult to, so that is one thing which you always keep in mind, that if there is, there could be small bowel adhesions which may be more troublesome and difficult to predict.
So in a Douglas pouch, whenever there is a puckering, chances of injury to the gastrointestinal tract, right? But now these patients, we have started surgery and the rectum is opened while taking the Douglas pouch. How will you diagnose it? What symptoms and signs will be there?
So first thing is if you have prepared the rectum, then you may not find anything that comes through the rectum.
Yeah.
So that is the big problem. You will only have some mucosal pouting, and if you are good enough to recognize that, then that's a very good thing. What we have seen is everybody commonly does methylene blue test. They will instill methylene blue in the rectum. We have 1 or 2 problems with that. One big problem is the methylene blue stains the tissue so badly that if there is a leak, it becomes very difficult to identify the edges of the tissue and suture it. And as sir said, we want to know whether the rectal wall is actually viable. And with methylene blue staining, it makes it almost impossible to judge whether the wall is viable or no. So what we recommend is simple installation of saline and betadine in the rectum. You give again the problem is it may not leak because the rectum, you remember, is a very capacious organ, it's continuous with the colon. Whatever you instill just goes in the colon and may not come out. So you have to be patient, keep a Foley's bulb inflated in the rectum, instill saline and wait for some time for it to leak. It may not, like bladder, it may not come out immediately. So wait for some time. And if you diagnose the rectal leak, don't try to repair it locally. I think it's better to convert.
Okay.
So, here, the choice of hysterectomy, I would go for LAVH rather than NDVH. Okay. So again, because if whenever you have puckering, you have endometriosis, she has already undergone 1 surgery before. You know there is endometriosis inside, like ultrasound findings, sir. Many times we bowel endometriosis we miss. So your history taking dyschezia, dysuria, dyspareunia, bladder endometriosis. So now role of MRI and ultrasound very, very important nowadays. It is evolving thing. I think last CME we had discussed about the ultrasound things about endometriosis. So very important that deep infiltrating endometriosis, because again you do NDVH, her main problem of dyspareunia, dysuria is going to come and she will again land with another surgeon for another surgery. So very, very important, put a scope, diagnostic scope you put inside and then you take a call whether you want to go ahead with LAVH or you can go back to your
laparoscopic
I put in a different manner. Guram, next time don't put this type of cases with 38 years.
Okay.
All of us will be sued. इसको 40
Okay.
साल करो सबसे पहले तो 38 years and hysterectomy, we are all stuck. Number one. Number two, we are not going to do. I am telling you until and unless it's a real important. Then the chocolate cyst of 5 into 5. And you have a great sonologist in a town. So same thing what he has said कि हमको बावल चिपक रहा है उसका grading तो grading can be done everything with the sonography. So we pre-hand know what is the status of this. And if we feel that this thing is not possible with our sonologist, an MRI has got the role before doing this surgery. And this type of patient before doing surgery at least 3 months. See, we have to give the medical management to this type of patient before doing this surgery because this is 38
It's
years
okay,
is
it's
wrong.
okay.
I'm sorry
But
to
only
say
thing
it.
is, in a normal
but
patient,
in a pre-hand we should know क्या चिपका है क्या नहीं, where is the
in a
adhesion,
cystoglandular hyperplasia patient, that is a real indication. Suppose that patient
and
for
what he suggested in this case is that we should go for the laparoscopic assisted vaginal
Yeah,
surgery.
that's okay.
It's good, or a first look by a laparoscope and then do the vaginal surgery.
I will just, I want to ask about the complication.
If we may
Suppose in this is not a case, a patient of, we are doing vaginal NDVH, accidentally the rectum is opened. It happened. So how will you advise us to
So
go
one
further?
has to remember that whenever the rectal injuries during vaginal hysterectomy and abdominal are different, because here you will tend to cause lower rectal injuries and in abdominal you will tend to cause high rectal injuries.
Yes.
The difference being that the lower rectum is a very high pressure zone due to the presence of rectal sphincters. So the leak rates of low rectal injury are much higher than high rectal injury. In fact, surgically we will take low rectum and high rectum as completely different organs. They have completely different problems. So lower rectum, if you have low rectum, if you are injured during a vaginal hysterectomy, I feel personally it's not appropriate to just take stitches and sit tight and wait for something to happen. Something will happen. So better to, I think, convert these patients to abdominal hysterectomy, assess the rectal injury properly from above. It will be difficult because it will be a very low rectal injury. You'll have to dissect in the planes and go, most of the times it is possible. If less than 1/3 of the rectal circumference is involved and if it's not a thermal injury, then if it's a clean cut by a scissor, if it's not a thermal injury, then we'll maybe repair it and wait. Put a drain in the pouch of Douglas and wait. If it is a thermal injury, if the patient has got a circumferential rectal involvement of more than 1/3 of the rectal circumference, then probably not, we will always do a rectal repair and a diversion colostomy and a drain and wait. There are some papers, I think especially Kadir sir, who is working with Professor Norman, they are doing serial CRP monitoring every day in patients who have undergone a rectal resection, and what they do is if the CRP trend is rising, they will again put a laparoscope, see the patient, if there is any chance of sign of leak, they will do a proximal diversion colostomy. It's difficult in our setup, it's a little bit controversial, but if it is more than 1/3, I will definitely do a colostomy.
Okay. It is a clean cut injury. I am seeing the upper edge, I am seeing the lower edge. How to proceed in that case?
It's a low rectal injury?
Yeah.
Yes. Then still, if it is, depending on the circumference that is involved. If it is very small injury, yes. And if it's a young patient, no comorbid illnesses, let's say this may be a 40-year-old patient, no comorbid illnesses, you can still repair the rectal injury, less than 1/3 involved, clean cut injury, you repair the injury with delayed absorbable sutures, preferably use PDS, delayed absorbable, and put a drain, put a large bore pelvic drain, and monitor. Don't remove that drain on the second posterior day setting. A patient ने एकदा संडास केली आता drain काढून टाका. Remember the leak rates for the rectum peak are between day 7 and day 10. So your patient may have passed stools once or twice. Don't be in a hurry to remove that drain.
So 10 days. Okay. So these are the two complications which we most fear. Okay. Now, 48-year patient, nulli gravida, laparoscopic surgery for infertility, now complaining of PU bleeding from 5th month, single fibroid uterus 20 by 40 centimeter, on perspective examination cervix normal, high up, uterine size 16 weeks, mobile, hysterectomy, patient want vaginally. In this case, which complication you will expect? Any specific investigation you needed? Can we predict successful vaginal hysterectomy? And Power sir.
Yeah. The most common, like now, madam has already given lecture about 20 weeks fibroid, so I think she will prefer vaginal route. But here, 16 weeks uterus, if you are planning for hysterectomy, under examination under anesthesia, trial of vaginal hysterectomy, if the any uterus which with traction becomes a pelvic organ, under anesthesia, maybe without anesthesia it may not become pelvic, but when you give traction it goes into the pelvis, those you can do vaginally safely. But always have to convert it into abdominal or laparoscopy.
This case put in front of you because the chances of there are big vessels and there might be primary hemorrhage or secondary hemorrhage. For that complication, I have taken this. The scenario is, on table there is a bleeding, there is a primary hemorrhage. So how to tackle that?
Vaginal hysterectomy.
Yeah, we are doing vaginally. Then how to tackle that?
First and foremost, chance of the bleeding, slipping. I'm not able to catch the uterines, or if we have already, then the chances of bleeding. How to proceed? It's a very skillful question, I'm telling you. It's not that there is a 1, 2, 3 for this. Ye kar lo, ye kar lo, ye kar lo. No, it's not like that. What will happen at that time, it's tough, but a good packing and finding the vessel through eyes. Yadi aankh se dikh raha hai kuch, then think
That
over
answer
it.
I wanted.
If you are not able to see the vessel from which it is bleeding and you are not able to, sometimes that's so bad.
So,
if not really, pack from vagina, open the abdomen, say sorry to the patient, do the counseling and complete the surgery. That's the number one thing which you do. And if you're, and just don't go on clamping something which you are not able to see. So that's the primary thing which is very, very important.
This is important. For that only I have put this question. If the vessel is, you are seeing the actually pointing vessel, they can very well catch it, but don't just clamp it without seeing that. And there are chances of more complications.
So here what is important is to anticipate these injuries. So what we can do is, instead of like we do it in 3 clamps on each side, so you can do a small bite simple clamp. So whenever you are suturing into the vagina, your sutures should occur at the level of your ischial spine. So anything, don't clamp anything beyond the ischial spine. So then if you clamp and cut, then there will be bleeding. So you take small bites, chote bites given maybe 1 centimeter at a time, 1 centimeter at a time, and take many pedicles, or if you are doing it bipolar, whatever. So that is one thing. And very, very important is your suturing skill. What is happening nowadays, everybody is using bipolar and using, and they don't know how to suture with hands. Suture, that is very problematic.
Now once you use, the thing is, here I want to refer. If you are ligating and then you are using bipolar, don't do that. Either use one thing. Either do it completely with bipolar, or either use suture. Don't combine it.
Right.
Sometimes you have to be used to both the methods.
No, because
no.
Sometimes you need it. You catch the.
Yeah, but after ligating, don't use bipolar. You will undo the.
After ligating, you
don't use bipolar.
After cauterization, and
you can use laterally.
That the chunk is big, you should suture it.
So these are in front of you, most common site, uterine ovarian vessel. Don't panic. Visualization is important. Suction, proper light. See for the source of bleeding. Catch it with Ellis forceps. Pointed small tip instrument like mixture. Arrest bleeding by ligating again or cautery with bipolar. Confirm hemostasis. No blind clamps. Large hematoma in broad ligament may happen. Packing of pelvis in some cases with watch on vitals. But if patient is stable otherwise, so SOS, there might be required internal iliac ligation. Now, in this scenario, this patient was gone to post-operative care. Yeah. This patient went to post-operative care, and then suddenly her blood pressure is decreasing, tachycardia is increasing, oxygen saturation is decreasing. So here again the chances there is a secondary hemorrhage or slippage of ligatures. How to tackle this complication?
So whenever we have such hemorrhage type of things or big size uterus, I always keep a drain vaginally. So maybe even a RT you can put inside in the vault and just take sutures over that. So whatever bleeding inside is there, it will be seen outside. And if this such a situation occurs, you have to immediately take into the OT table resuscitation and exploration vaginally or SOS abdominally for internal iliac ligation. That is very important. And immediately you have to do this means like your ruptured ectopic, quick in, quick out.
Okay. Sir, I am asking about to Meru sir. For regarding the whatever I have just said for secondary hemorrhage, what investigations will be helpful?
First do the ultrasound, sir.
Ultrasound.
Put the speculum and seed first.
I know, ultrasound.
By the time you come down, we can put the speculum and seed.
And put a two lateral big clamps over the vaginal wall. Most of the bleeding will stop. If the secondary hemorrhage is there, if there is an angle with angle, you just put both big clamps of coccus sort of clamp on the both. This is because of the like a PPH we also save from vagina, just putting the pelvic septum same and the bleeding stops.
Okay. These are some other methods. The packing, which we said, right? Sir, again to Meru sir, the best imaging method to know all various types of complications.
Ultrasound.
Yeah.
If you're anticipating any adhesions or something like that, I would prefer CT or MR to diagnose. He said small bowel obstructions sometimes may be difficult, but if the adhesions are there and patient comes with obstructions, even small bowel obstructions can be diagnosed on computed tomography. And rest we discussed, sir.
Yeah.
Okay. Infection abscess, first ultrasonography. If you don't get precise anatomic landmarks, then go ahead with CT. Bowel perforation obstruction, first, if possible, if the X-ray is possible, see for the gas at the domes of diaphragm. Then maybe CT or maybe direct exploration.
Our choice is always a CT.
Okay. If you see gas under both
sir, because once we have opened the peritoneum, then gas under diaphragm becomes a very difficult thing to interpret.
CT localized
Yes, so I think better way is to, because we have seen many times these fallacies, better to do a CT. I'll tell you the reasons why. Because if we are talking about rectal injuries, the amount of free gas after rectal injury may not be very much, so you may miss that. Second thing, you may not have that collections like small bowel perforation, multiple large big collections, they may be small collections may be missed on ultrasound. So I think and we don't have time here, because time is an essence. So better to go ahead straight away with a rectal contrast CT that will most of the time tell you whether there is a rectal injury or not.
If the patient is not in a position to give contrast, or maybe
we don't give IV contrast, sir. We'll only give rectal contrast.
Okay.
We'll only give rectal contrast. We don't need IV contrast because we are not suspecting any ischemic or anything. Best colonoscopy, no, because colonoscopy makes a bad situation worse, because they will just put the scope and it will go in the peritoneum. It will actually aggravate the perforation. We never do a colonoscopy. Okay. Best is a good quality rectal contrast CT, instill adequate amount of rectal contrast, and do a plain CT with a rectal contrast. That much is sufficient.
One more thing I would like to add is, as clinicians, we should be aware about what are the limitations of each imaging modality. Nothing is sacrosanct or 100%. I'll give you an example which I faced, that a patient underwent a vaginal hysterectomy at a nursing home, following which she had persistent burning while passing urine, and the urine continued to show a lot of WBCs. Culture was done, antibiotics given, but no relief. So after 3 months, I was called into picture 3-4 months later, and an ultrasound was done, which was reported as having a vesical calculus. So there was a possibility that a stitch had gone and a stone had formed over there. On KUB, it was not seen. Very often infective stones of the bladder are not picked up on KUB. So I did a cystoscopy, and it was a very difficult thing to visualize. The vision was not at all clear. And this was in an era where cameras were not routinely available. So we used to do it with the eye. And using a Mormeyer stone punch, I tried to catch hold of the stone, but few fragments, calcific fragments came out. But ultimately I could catch hold of a good chunk, and along with the scope I took out, and what came out was a pad.
Okay.
And nothing happened to that patient. So that is God's greatness.
One more practical thing we see, sir, in daily practice, lot of time is wasted in doing multiple ultrasounds. In the post-operative abdomen, remember with the post-operative abdomen, gaseous distension, ultrasound is again very difficult to interpret. And many times, nahi sonography normal is ki kai nasnar, sonography normal is ki kai nasnar. And with rectal injuries, the time is an essence because to intervene very fast, otherwise patient will not survive.
In rectal injury, as far as rectal concern, CT is the best modality, that's for sure. Then the bladder perforation, CT cystography is fine.
Okay.
CT stress cystography is important, not CT cystography.
Okay.
Because what happens is in stress cystography you are going to adequately distend the bladder.
Why not MCU then?
You mentioned CT, so I added stress cystography. I would say if it's a bladder injury, you distend it and you've done a vaginal hysterectomy, you distend it with saline, you would pick it up there and there itself. The role of CT hardly comes.
MCU is first. Ureteral injury, IVU, best. If they want more information, go for CT urography. Vesicovaginal fistula, MR is non-invasive, and even cystography.
Can you emphasize a bit about people doing a contrast-enhanced CT and a CT urography to pick up a ureteral injury? These are two different things.
Yeah, CT urography is a delayed procedure in which it is like you are like IVU only. You have to wait for some time.
This is something which a lot of clinicians don't realize, that a CT scan, when it is done with contrast, and unless you have given a proper history, is finished within 5 minutes, 10 minutes. Its delayed images are not taken. But a CT urography will invariably, the radiologist will take delayed images, and that would give you an idea about a ureteral injury. So a plain contrast enhanced CT and a CT urography are two different things, and plus how good that CT machine is and how diligent that radiologist is in correlating that history with his imaging is equally important.
But nowadays are all setups are having fantastic good machines, so that's not the problem right now. It was the oldest problem.
Okay. Now we are coming to some common complications. Sometimes patients come like this post hysterectomy. What is this? And how to prevent it and how to manage this? Power sir.
First important, how to prevent it. So this is basically when you are doing vault suspension, if you are taking the cornual pedicle and tying it to the vault. So nowadays we don't recommend to take the cornuals along with the tube down. Second important thing in vaginal hysterectomy, do the salpingectomy. Opportunistic salpingectomy. So because nowadays it is the recommended step associated with, it's a part of the step of hysterectomy now. So then these things will not happen. And
in fact, if you want to remove the adnexa, so through practice always do femorectomy. That will prevent this femoral prolapse, and at the same time you will get the practice. And this is the granulation tissue. It sometimes, this also can be treated with copper sulfate. Okay. Sometimes this patient actually came from Vijaypur, post-operative 12th day. This complication can occur. So for us to, I am asking this question to the surgeon. Post-operative 12th day, patient came, after vaginal hysterectomy, patient came with this. How to manage?
But what is this? I am not getting.
If we say completely through the vaginal wall.
Acha, that is the bowel, okay.
Yeah.
No, you have to do a laparotomy, there is no other choice. You have to go ahead and do a
Laparotomy.
Patient will be very sick.
Okay.
I think Girish Kuntekar sir, he is not, he will remember one such case we have managed. There was a foul smelling discharge from the vagina and he thought there is some gauze beads left in the vagina. So the patient was operated elsewhere, he just removed the gauze and all the bowel and feces, he was smeared with bowel and feces.
Then this is a late complication of vaginal hysterectomy. It is a late complication. So to prevent, what advice you will give at the time of surgery? I am taking all the complications.
So I think the proper wall suspension and sacrospinous fixation if it is required.
Prophylactic scaldoplasty.
Yeah.
You do the
Kalyan stitch.
and just put a sutures, both the uterosacrals bring together and suture it. But in a non-descent hysterectomy, this
Generally
type of wall prolapse, इतना तो नहीं होना चाहिए ऐसा मेरे को लगता है. Prolapse में what prolapse हो सकता है?
Okay.
One thing I would like to tell you about the previous, like granulation tissue,
Huh.
we used to cauterize with copper.
Sulfate. Yes.
Silver also, madam. Silver पण
We
लावायचं.
used to do it with those blue
Copper sulfate. Yeah.
copper and it disappears.
चाललं जायचं.
Now, sometimes patients came after vaginal hysterectomy complaining of tingling numbness. So, how to prevent this and what are the causes?
First is
Positioning is
of
very
the
important.
patient while operating. Lithotomy, extra exaggerated lithotomy, that itself gives rise to
Duration of surgery.
Yeah.
duration.
Duration of surgery sometimes.
First is position of the patient while doing surgery, exaggerated lithotomy, pads below, pads under the knee. These are very important and the procedure should be short, if a properly selected patient and if your mind is set up, this is this case and we are doing it this way, so it should not prolong for a long time.
Okay. And the assistant should not keep his weight on the patient's.
They rest,
Invest in good OT table. That is very important.
Yeah.
Don't use shortcuts in saving money on the OT table. Very difficult
Now you
later
are
on.
coming-
And another important, the time of the surgery, duration. Never ever, if your duration is prolonged, that means you are going to have all these complications.
Now I am coming to the last slide. Common with many times it is seen. You are doing vaginal hysterectomy, after putting speculum in the posterior fornix, then comes the soiling of the operative field. Most common, how to prevent and how to take precaution. Yes.
Stool pass कर तो
This is the most common complication at the time of surgery.
First is after spinal, when you give position to the patient, that's the time this happens.
But
Sometimes.
why it happens if we have not done the proper preoperative
Yeah,
preparation?
that's why
Do
this question.
proper preoperative- this
So
is-
what
is it a
preoperative care should be taken? I want that answer.
This is not a complication,
not
this
a
is
complication.
mismanagement.
This is not a
You can
complication.
say this is
For complication for
mismanagement.
us,
No, this
You
is
can't
not
say
for the
this is
patient.
Madam, this is not a complication. This is improper preparation of
Okay.
the patient.
Mismanagement.
Mismanagement.
And then the gynecologist has to do everything.
No, no, no. This is not a complication.
Yeah.
So what preoperative precaution one should take? What?
ये कौन सा complication?
नहीं complication नहीं है, but I want a preoperative preparation.
The do proper preparation of the bowel.
So when
और हमको नहीं आता है तो सर्जन से पूछो वो बताएगा
नहीं,
क्या
क्योंकि
क्या करेगा.
ये कॉमन क्वेश्चन है और सबको यहाँ होता है.
I know.
So that's why I put that. काय
And
कधी
when
द्यायला
you
पाहिजे
sta- when you
एनिमा.
sta- when you
नहीं
start
होता
the when you
गुरु
start
में
the
नहीं होता है.
operation,
कॉम्प्लिकेशन नहीं है ये.
नहीं ये सॉइलिंग भी नहीं होता है.
नहीं.
यदि 2 केसेस में हुआ तो स्टाफ की तो नौकरी जाएगी.
नहीं, लेकिन आप कैसे प्रिपेयर करते हैं ये बताओ हमें.
वो that's what I'm
अरे
saying.
एनिमा देने का ना tell patient to have
द्या ना 8 गोळ्या द्या,
light,
bowel prepare करा,
diet.
do everything.
खाऊन
But
बाहर
patient
होता
should not soil in our OT.
That's it.
Yeah, that's important. वो क्यों soil करेगा कमरे में?
Suppose it happens. Suppose it happens. How will you go further? कारण सगळं सॉइलिंग झालंय.
To pain drape again, but if patient is still passing, then you can put some mop into the
That is the
pack into the
Yes.
rectum. Vagina.
रेकम पैक करो बाद में निकालो.
और
Yes.
बाद में afterwards take a
So-
stitch to
What
the linen from
what generally
the
I
fossé.
what generally
From the
I do
fossé.
is when we are drape the patient, I put a gauze piece on the anus, and I take the stitch at 6 o'clock position with the gauze piece and the drape.
Linen also.
Tie it over there. So whatever is going to happen will happen behind.
And the last resort pack. Last resort pack. Now this is
पर्दे के पीछे होता है.
many times if you use 2% xylocaine, this complication can occur and that is dreaded complication. Suppose it's a fibroid uterus, it is vascular and you are using 2% xylocaine for aqua dissection.
This can happen with episiotomy also.
Yeah, but this is the most important. Depending on the serum concentration, initially the patient will show lightness and numbness of tongue, visual and auditory disturbances, but as it is increasing, patient can go into cardiac arrest. So that's why don't use 2% xylocaine for aqua dissection. I want to give this message. Thank you very much. Thank you all.
Thank you, sir.
Thank you all the panelists and Dr. Gurram sir. I request our president Dr. Virkar sir to please felicitate the panelists. Dr. Sharma sir and Dr. Meru sir, please come on the stage. Sharma sir. Sharma sir. Dr. Meru sir. Dr. Vakade sir. Dr. Gurram sir, please come on the dais. Chitnis madam, please come on the stage. We want to felicitate you as a panelist. Dr. Bapat madam. Dr. Kavita Bapat madam, please come on the stage.
Oh, sorry.
Thank you, sir. I request Dr. Khare to present vote of thanks.
It gives me immense pleasure to give vote of thanks on behalf of my team. Especially, I want to thank Kavita madam, and I request all SOGS members, and I give assurance they will cast in favor of you. Okay, and thank you all for attending this conference.